guys, welcome back. I am super excited to present to you the newer version of rapid revision. And what better topic to start than rather starting with cardiology? It would be like hitting the nail on the head. And the first topic that I'm going to discuss with you here would be myocardial infarction. And most of the time in the exam, they love to ask regarding infarct localization. Not only this is important for a PG entrance exam, but even in your FMG exam, they would be giving you a ECG with a short history and would be asking you regarding whether it's an anterior wall versus an inferior wall versus a lateral wall MI. So let's get started. But first of all, let's understand what MI is all about. And why this topic is important is because coronary artery disease per se contributes to the max amount of mortality in India. You see, India is anyway the diabetes capital of the world, and the number one reason why diabetics would be dying is again per se cardiovascular causes, and that would be ranging from ST elevation to non-ST elevation MI to unstable angina. If they're not handled properly, the guy would end up with heart failure, severe pulmonary edema, and he can die. So let's look at what actually happens during myocardial infarction. If I just zoom in, this can be taken as cut section of any one coronary artery. It could be left anterior descending, left circumflex, right coronary artery. And what you see in yellow here is the fat deposition. So I can call it the lipid core. And what I've shown in green superiorly, this green is actually the fibrous cap. So atherosclerosis as a word that you read would be having two things present: a lipid core in the middle, that is in tunica intima, and then covering that would be a fibrous cap. And when blood is going through this coronary artery at a fixed amount of pressure, what really can happen here is, and that's going to be bad news, that there could be a development of a tear. There's going to be a plaque fissure, and the moment there's going to be a plaque fissure, there would be exposure of collagen right deep inside the blood vessel, which will cause the platelets to jump onto the opportunity. You see, I can draw parallels there. Like if you're shaving in the morning, you get a cut from a shaving razor, the collagen in your blood vessel will be exposed and the platelets will jump onto the opportunity. The same thing is happening here as well. Because of this plaque fissure, the platelets would be attracted to collagen. I mean, collagen will act like a magnet here, and very soon there would be a platelet plug formation, and then there's going to be a clot formation, a thrombus formation, and this thrombus is going to occlude the entire lumen of this coronary artery. And within the next couple of minutes, once this coronary artery gets occluded by a thrombus or a clot, you would be having muscle death, you would be having myocardial necrosis. I will be describing to you technical meaning of the word myocardial injury versus myocardial infarction. Yes, they're different, but at the moment, I want to say two facts which I'm not writing, but this would give you insight from the treatment perspective, that you read about MI being of two varieties, that is ST elevation MI and non-ST elevation MI. Why that classification is because what we have found subsequently is that in ST elevation MI, the clot is rich in fibrin and RBCs, because the clot in ST elevation MI is rich in fibrin and RBCs. Therefore, fibrinolytic drugs like streptokinase, L-teplase, re-teplase, tenecteplase will work. On the contrast, when you read about non-ST elevation myocardial infarction, the clot happens to be platelet rich. Because it is platelet rich, therefore we shall be using mainly antiplatelet drugs, antithrombotic drugs, but we'll not use thrombolytics. Thrombolytics are not effective with respect to non-ST elevation MI. In fact, in routine video lectures, I always say thrombolysis is contraindicated in non-ST elevation MI. So I'm going to write that data subsequently, but the basic concept is two facts. ST elevation MI is fibrin rich, so fibrinolytics will work. But the same strategy is not going to work in a non-ST elevation myocardial infarction, because we don't have a fibrin-rich clot, or rather we have is a platelet-rich clot. So you need to, adjust your strategy according to the opponent that you are having. And therefore, let's now focus on this ECG that would be given to you. It's a standard 12 lead ECG. And most of the time in the exam, what they do is that they give this ST elevation mainly in lead number 2, lead number 3, and lead number AVF. I mean, every time you come across a ECG, the first thing when a question is beginning with chest pain, you are anyway thinking in terms of possibility of myocardial infarction in a patient. So where should you look at? Obviously, you should calculate the heart rate, and for calculation of the heart rate, I've discussed subsequently the strategies that you'll be deploying, and I mean, what is the best way to calculate heart rate in the shortest possible time. So this would come subsequently, but at the moment, I just want to say that because this is rapid revision per se, and they ask about infarct localization, which surface of the heart is involved. So I want you guys to remember the fact that whenever it's going to be the inferior surface of the heart, the inferior surface of the heart would mainly be composed of the right ventricle. Some part of your right ventricle is going to be facing the sternum. But at the same time, a large chunk of the right ventricle is actually niche. It is facing our diaphragm, and that would be the inferior surface of the heart. So most of the time in the exam, they would be giving you inferior wall MI, and for anterior wall MI, I'll show you a ECG subsequently. But where are you supposed to check out for anterior wall MI? In anterior wall MI, the findings would mainly be present in lead number V1 to V4, though you could be having findings in V5, V6 for a lateral myocardial infarction as well. But at this particular juncture, the minimum that I want you to remember is that MIs of two varieties. I told you the fundamental differences. And when it comes to inferior wall MI, which coronary artery will be affected, where there's going to be a thrombus present, your answer from anatomy, because integrated questions are asked, this would be a right coronary artery thrombus. So your capacity as a doctor should be that should you not only be able to identify a MI in the exam, but you should also be able to tell which coronary artery is affected. And if I just zoom into this image, what you can notice is a very characteristic. You can see at the moment is the P wave. Then there is no Q at the moment, but you can see is R going up, and then this is that characteristic ST elevation which is present. In fact, the term that I can use for this would be called as a tombstone pattern. It looks like a tombstone because the person is gonna go to God. So what I'm saying is in ST elevation MI of the inferior wall, what I've shown is a ST elevation. STE is what I'm writing, and this ST elevation is slightly convex in a upward direction. This is strongly in contrast with what we shall be studying subsequently, but I'm just going to hand draw that before you. There is a possibility that in the exam he could be giving you a ST elevation, but it's not going to be convex. In fact, you can notice at the moment that the ST elevation that I've shown in this particular case is concave in an upward direction. And this is what you are going to encounter if there's inflammation of the outermost layer of the heart. So right at the onset, do remember every time you are having a MCQ with chest pain and you are looking at ST elevation, don't assume it's going to be MI. It may be a trick up the sleeve of the examiner. You need to look whether it's going to be convex upwards. I mean, if you look at this diagram, you can see the curvature going upwards. No, so I said convex upwards, whereas if it's going to be concave upwards, it could be acute pericarditis. How would you be sure? The question will also mention regarding the report of cardiac biomarkers. He could talk about the blood report or troponin T or troponin I or CPKMB. So biomarkers are always elevated in MI, but biomarkers are usually normal with respect to acute pericarditis. Now, once you understand that always, I mean, whenever he's talking about infarct localization, your eyes should always focus on lead 2, 3 and AVF, because traditionally when they teach you the ECG, when you go the conventional way, the problem is that in the exam, because there's limited time, you have about a minute for an MCQ, you need to learn hacks, you need to understand ways to crack the question, and therefore this was, I would say, a hack. And at the same time, if you cast a glance at the chest leads, you will notice reciprocal changes occurring here. I mean, by what I'm drawing at the moment is the opposite, right? There's a ST depression with respect to chest lead like V1, V2, V3 and V4. So reciprocal changes or opposite changes would be faced with or would be seen by you in the anterior leads, but there's a very characteristic ST elevation present in the inferior leads for this particular ECG that I've shown here before. Now let's just focus on the ECG findings in MI. I mean, let's have a look at the sequence with which the findings would be appearing. And initially, once you have a myocardial ischemia, there would be a change in the polarity of the T wave. Why T wave is affected? Why not P? Why not QRS? Because PQRS represent or they are a part of what we call as the PQRS per se represent absolute refractory period of the heart. You see, from physiology, you know that if any muscle is going to be in the absolute refractory period, it's not going to have any impact. I mean, even if you stimulate it, right, it's not going to show any changes. But when it comes to the T wave, That is the relative refractory period. So the changes are initially seen in the T wave only because the heart at that point of time is in a relative refractory period. And if he puts up in a question, what's going to be the initial first ECG finding in MI, then do not answer ST elevation. It may be seen, it may not be seen, because I said at the beginning, MI could be of two varieties, right? A ST MI and a non-ST elevation MI. So your answer in this particular case for the earliest ECG finding of MI would be given as hyperacute T waves. A word of caution there, the word of caution is do not mix this up with tall tented T waves. You are going to read about tall tented T waves in hyperkalemia. We are going to cover that subsequently also, but the word of caution is tall tented T waves is going to be hyper K. This is going to be hyperacute T waves, and the problem in this case would be that the height of the T wave will definitely increase. And at the same time, what you also need to notice is that what should be the normal height of the T wave, because after all, if in the exam you have to pick up that the T wave is relatively taller in size, or I can say hyperacute per se, you should know the size criteria. So as far as T wave is concerned, do remember that the vertical height would be less than 5 millimeter when it comes to the limb leads, and this would be less than 10 millimeter when it comes to the chest leads in the patient. So if it's going to be like more than 10 millimeter, that is 10 small squares, bigger than that, then I'm going to call it either a tall T wave or a hyperacute T wave. And for MI, the nomenclature is hyperacute T wave. The next thing that will occur in these patients would be the changes in the ST. And well, ST would be the end of the S. The green dots that I've shown, that would be the ST segment. So what's going to happen subsequently would be that this ST segment is going to follow the T wave. As you can see, T is going up. So now the ST would start going up. And let's look at the ECG of the same patient after, I would say, a few minutes. So coming to the second finding of this patient, and I'm just going to redraw this ECG once again before you. This was P, then we had a PR interval. PR interval, by the way, the name is PR, but it is not from the starting of the P to the peak of the R. It's not till the peak of the R. It's actually the starting of the Q wave. The name is PR interval, but it is not up to the peak of the R. It is the starting of the Q wave. So what you can see is R is going up, but then at the same time when R is going down, I've shown is a ST elevation. And at the same time, now there's also a change in the polarity of the T wave, and it is turning out to be negative. So what I have now shown before you is a striking presentation of ST elevation. Well, you should be aware of this ST elevation for males and females. I mean, how much are you gonna consider it significant? So for a male patient, if the ST elevation should be at least 2 small squares, for a female patient, this should be at least 1.5 millimeter, and it should follow a particular pattern. Like if it's gonna be lead number 2, 3 AVF, then it's always gonna be inferior MI, and if it's gonna be 1 AVL, V1 to V4, especially remember V1 to V4 at the moment, it's gonna be anterior MI. I mean, this is going to be significant per se, and this would be associated with development of a T wave inversion also. So the polarity of the T wave will change, but make no mistake, lots of time you might be even having a ST depression also. ST may be normal, or there might be a ST depression also present. So we're going to call it a non-ST elevation MI. At the moment, I'm focusing on mainly ST elevation that would be occurring, and I've described before you is a significant finding of at least 2 millimeter for males and 1.5 for females. Now would come another interesting finding, which is with respect to the depth of the Q wave. Normally, the Q wave is written as a small q, and it fits into one small square of the ECG. But as there would be death in the heart, I can put it like this: heart is positive. Let's take it like that. Heart is working, heart's positive. If you have death, death contributes to negativity. Negativity will cause the negative waves to become, I would say, relatively more deeper, and the positive waves to become relatively smaller. I'll repeat the mathematical fact once again, because there is death occurring. So negative waves will become more deeper, and the positive waves will be rather decreasing in their amplitude. So here what I'm saying is that there would be another finding coming up, that would be the depth of the Q wave will increase. So you will always read this word pathological. He's always going to write the word capital Q. That is a pathological Q. Even if he does not write the word, pathological, but if he writes the word capital Q wave, you should always consider it to be abnormal. So Q waves would start coming up, and well, what are these Q waves representing? They're representing cell death. And cell death is going to be irreversible, right? I mean, you just can't change death. Even if you thrombolize this chap with a ST elevation MI who's having a fibrin rich clot, the ST elevation will come back to normal, but the Q wave of the patient is never ever gonna come back. So you might get a question that might say which ECG finding indicates presence of a previous myocardial infarction or an old myocardial infarction. Then, let me say the guy had MI, at the time of lockdown, and he had big hassles with respect to getting admitted because all hospitals were COVID hospitals at that point of time. And luckily, I mean, he was admitted, he was treated. So you might have a person who might just come to you with the ECG subsequently, and if you find these deep Q waves present, let me say in lead 2, lead 3, and AVF, you can tell him, sir, you probably had an MI earlier, and he says, yes, yes, sir, that's what happened, maybe about 2 years ago. So this finding is gonna persist. I mean, that's another way the question was asked, that which ECG finding persists for whole life of the patient. Then it's gonna be deep Q wave, and as you can understand, they love to correlate this with the I would say pathology. So the message here is that I can divide this discussion like this, that if he's going to talk about which of the following findings would be indicating myocardial ischemia, then myocardial ischemia is going to be hyperacute T waves, but then subsequently there would be myocardial injury coming up. Myocardial injury is best identified by cardiac biomarkers. Remember my words. If he says what is the best test for diagnosis of MI, don't answer ECG. If he says what is the best test for diagnosis of MI, it is cardiac biomarkers, because if there is going to be myocardial necrosis, if there's going to be an injury occurring in the patient, then those cardiac biomarkers are going to leak out of the myocytes. Cardiac troponin T, troponin I, they're inside the myocytes, they would leak out. But from the exam perspective, if he uses this MCQ, which of the following is called as current of injury? The current of injury, the language of the MCQ is which of the following is called as current of injury, then your answer would be given as ST elevation. Then subsequently, if anyway mentioned it, I'll just use a different color to highlight the fact, because I'm trying to integrate the medicine component with pathology. So we have ECG findings of ischemia, we have ECG findings of injury, and then there would be cell death occurring in the patient as well. We'll talk about the clinical domain also, but this is how it occurs. No, first you have a ischemia, then you have an injury, and then finally, subsequently, you would be having development of cell death. As far as these deep Q waves are present, it might take approximately minimum at least 1 hour for this to occur. So I can also put it like this, that as soon as the coronary artery will get occluded, I mean, as early as within few seconds of the occlusion, the coronary artery, hyperacute T waves will be developing. After a couple of minutes, it would be a T wave inversion and a ST elevation. Though I told you, I mean, they could be even a non-ST elevation MI as well, but you still would be having a T wave inversion. You still would be having doubling of the biomarkers, and the treatment between the two is what is usually asked in the exam. So you can see the sequence. It is second, minutes, and hours, as I've explained to you. So if he says which ECG finding indicates cell death, I think it's very clear right before you that you would be giving answer as deep Q waves. Now, once you get the ECG findings right, what I would like to emphasize next is, and this is a snapshot from Harrison, where he especially talked about myocardial injury and myocardial infarction. You see, I spoke about current of injury, I talked about ST elevation, but the most important way, how do you identify myocardial injury per se, is going to be with respect to checking out the cardiac troponin levels. Actually, the most of the kids, I mean, the kids might vary in different hospitals. Like, one of the kids might be saying that the normal values are troponin I. And why that's important is because lots of the time you might be having a telephonic call from maybe a school friend of yours. He has done engineering, you went into MBBS side, and he's just giving you a call and he's saying, my dad was having chest pain for a few hours, so our family physician has advised a blood test. And he might send you this report on WhatsApp, and this guy might be saying to you that, buddy, can you just let me know, is my dad suffering from a myocardial infarction? So different kids will be having different cutoffs, but like, how would you say that, how would you tell this friend of yours who's a non-medic, who's into, let me say, engineering side or management side, that your dad is suffering from MI? You need to check out the tropi values, and what is the minimum that is required is actually a doubling. You can be having a tripling also. You might be even having a 5 times elevation, you might even be having 10 times elevation. So I will tell you when do you get a 10 time elevation, when do you get a 5 time elevation. But the minimum that you are expected to know right now is that the report should be showing at least a doubling. Once you have a doubling, it indicates myocardial necrosis has already occurred. And in the MCQ, just to make this sound a little sophisticated, I mean, I told you the simplified version that the trop I values, once they're showing a doubling, that indicates a MI. In multiple choice question, what he's going to write is this statement, which I'm highlighting. The question will say trop I values above the 99th centile of the upper reference limit. I repeat that again. He might actually just make it sound sophisticated. That might overwhelm you. And why he has written at least one value above 99 centile is because troponin I values or troponin I is not gonna rise immediately, no. I mean troponin I, if they ask you when would the rise be occurring, then the rise, in fact, I'll just use a different color just to highlight this. If the question says how much is the time that it is required for troponin I to rise, then this would be approximately 3 to 4 hours, in contrast with CPKMB, which will be taking about 4 to 6 hours. So when I was a student at your age, we used to study mainly regarding CPKMB, but you guys mainly study about cardiac troponin I or cardiac troponin T. That's because we could be having a rise earlier. The problem is if the patient comes within, let me say, 1 hour, in a big city like Delhi, there are so many cardiology hospitals. There would be like AIMS Hospital one side, Safdarjung Hospital on the other side, and then you have RML Hospital, and then you have Max, and you have Fortis, and you have Polo. So patients are spoiled for choices, and a patient might be reaching the nearest hospital in, let me say, 1 hour, 2 hours. If he comes early, tropi values are going to be normal. And if tropi values are going to be normal, would you be able to diagnose MI? Yeah, ECG would still be showing findings, right? So that is why I said ECG is to be done first. But ECG alone should not be used for diagnosis or confirmation. Along with it, you should be having a biomarker report in the patient. I mean, any of the two is sufficient for diagnosis and initiating treatment. But if they ask you which is more specific, it is troponin I. And I just want to put a word here or a prefix here. The prefix I want to put here is the word serial troponin I. What I mean by the word serial troponin I is that if the patient comes to the hospital early, even if at 1 hour the report is normal, if there is a definitive necrosis in the heart, the value will start showing doubling within the next couple of hours. So you could repeat it depending on the protocol of your hospital. Like he came at first hour, you could repeat it at the 4th hour or by the 6th hour, but the treatment of the patient would anyway be initiated. So we're going to talk about the treatment as well, but the message is serial troponin I basically indicates it might be done more than normal. And as he has written here, at least one value above the 99th centile, which would mean that it will show up at least a doubling or a tripling. Now, when do you say infarction? Because this was injury. There are 2 points for injury that I've told you. ECG finding of myocardial injury, ST elevation may or may not be present, right? So the best way for identifying injury would be rise of biomarker. But and when I say infarction, and you will see these terms written like type 1 MI, type 2, type 3. So don't bother about them. Yes, I will teach you even the types of MI. We have one MI classified as which surface of the heart is involved. One is going to be like anterior wall, inferior wall, but then there is a separate classification I'm going to teach you. That's going to be related to the etiology of MI. That's type 1 or type 2 or type 3. In fact, there's type 5. There's the total of 5 varieties. So don't bother. I'll tell you methods or hacks how to remember that also for the etiological perspective. At the moment, focus on the fact that if a person is having elevated cardiac troponin values, along with that, what should be present? What can be present is obviously clinical symptoms. And what could be the clinical symptoms in a patient? So one of the symptoms could be presence of diffuse chest pain. Most of the patients might be putting their whole hand on the chest or a fist on the chest to describe the chest pain, oppressive chest pain. So there might be description of Levine sign. Levine sign basically means diffuse chest pain in a patient. If any person is having diffuse chest pain for more than 20 minutes, he has already taken, Eno, or he has taken Digene gel, Gelusil, all this routine over-the-counter kind of products which are antacids, and still the chest pain is persisting, we must run in for a ECG. And if there is new ischemic ECG findings developing, that means that, yep, there are problems in the patient. Or as I told you, there is development of capital Q waves, which would be written as pathological Q waves. And nowadays, anyway, we would be having a echocardiography also available. So echocardiography might be rather revealing presence of a regional hypokinesia. You see, my point is, suppose left anterior descending artery is blocked. So left ventricle will not be able to work properly. If left ventricle won't work properly, the contractility would be lesser. So he will use the word regional hypokinesia, or he might even use the word stunned myocardium. You see, stunned basically means sudden decrease in the contractility of the heart. So lots of time in MI, these terminologies like stunned myocardium will be used, and echocardiography will definitely tell you the fact that there is problems with the mechanical function, because there is less supply of oxygen, primarily due to a thrombus in any one of the coronary artery. So my message is, if a person is having elevated tropi, I'm just going to write it here, though it's already given in the text matter, but just highlighting this fact. If you're having a person who's having an elevated tropi and any one of these are present, any one would mean that I'm not gonna wait only for the ECG findings to develop in a patient. It could be only symptoms in a patient as well. Like a guy came, he's having chest pain, I ran a troponin, it's elevated, still MI. If I get ECG findings, great. Or for that matter of fact, if there's an echo facility and I get a hypokinesia, that again indicates that there's a problem in the patient. So we are trying to simplify the definition in this case. And overall, I'll repeat once again, the best test for diagnosis of MI, investigational choice for MI, gold standard investigation for diagnosis of MI is not ECG, it is elevated cardiac biomarkers with any one of the following. At this point of time, I usually get queries from a lot of young doctors like you that, sir, why did we not start with symptoms? I mean, after all, not symptoms important. I mean, you did not begin by describing somebody coming with chest pain. You told us chest pain after you spoke about, ECG findings and about troponin I. Then I want to highlight, guys, that lots of time, especially from our country's perspective, you might be having a diabetic and diabetes mellitus patients. One, they have asked in your exam that what is the leading cause of death in diabetes mellitus? It is cardiovascular mortality. In diabetes mellitus, you may not be having chest pain. In diabetic patients, because of the diabetic neuropathy patient, there might even be a development of silent myocardial infarction. This is itself a MCQ, that silent MI would be occurring in a patient of, your answer would be diabetes mellitus. And for that matter of fact, whenever you gonna read a question that will begin by describing a geriatric age patient, and then he's hypertensive, is also having diabetes mellitus, and he's having chest pain, I mean, if there's no diabetic neuropathy, chest pain would be occurring. So whenever he begins with a description of diffuse chest pain along with the aspects that I've highlighted, then myocardial infarction is to be considered. Now, what will we be doing if it's a case of ST elevation MI, where there's a 2 millimeter or maybe a 3 or maybe a 4 millimeter rise, let me say, with respect to a male patient? So there are two strategies what we can be using. One is, if you're having a cath lab facility available, you can shift the patient directly to the cath lab and we can do a coronary angiography. We can be using a femoral access, we can be using a radial artery access. Radial artery access would be preferred, and we send a guide wire retrogradely via the radial artery towards the heart. We do a angiography and we will be on the monitor able to see that the contrast would not flow forwards because the coronary artery is occluded. In these circumstances, we will then deploy a balloon and get rid of the thrombus. So the procedure would be for a non-medico, I mean, I'll use the word balloon angioplasty. But for you guys, technical people, we will use the word primary PCI. So if he says, what is the treatment of choice for ST elevation MI? Then your answer would be given as primary percutaneous coronary intervention. And this procedure should be done ideally within 90 minutes of patient coming in contact with medical services. Lots of time the term used will be either door to balloon time, or in some MCQs, instead of, like, the traditional word is door to balloon time, like whenever patient reach the hospital, door to balloon time. Or if we go the American way, the person would be calling up 911, and then an ambulance will be going into the house of the patient. So they will start from the American perspective, they start calculating from when the person was inside the ambulance. He has to be rushed to the hospital in the shortest possible time, into the cath lab. We take a radial access, we go towards the heart, do angiography, deploy a balloon, and it's goodbye to this fibrin rich thrombus. Everything should be done within 90 minutes. The term written would be either door to balloon time, or he might use this, what I'm just zooming in, first medical contact to device time. Both mean the same, right? First medical contact from the American perspective is, once he gets into the ambulance. From an Indian perspective, all I can say is patients might take their own sweet time to come. And once they enter into your hospital, your objective would be to do try to follow the American guidelines as much as possible. So do remember the treatment of choice for ST elevation MI, if asked in the exam, would be a primary PCI, and this should be done within 90 minutes of arrival of the patient to the hospital. But let me say that the patient is coming to your hospital and you're working in, let me say, in periphery of Gurgaon, or go towards Manesar, or maybe go towards peripheral side where may not you may not be having cath lab facilities. If you are having a non-PCI hospital, then what would you do in the patient? Then you would initiate thrombolysis. Now, when you are initiating thrombolysis in this patient, this should be started in the shortest possible time. So he will use this term door to needle time. The patient comes in and you need to start an intervention. So the door to needle time should be kept preferably under 30 minutes. And this would mean that obviously you would be giving standard drugs that you study. Morphine would be this mnemonic does not mean that morphine will be given first. Moon mnemonic or Muna mnemonic does not mean this is only a mnemonic. That does not mean that the morphine would be given to the patient. In fact, once the patient is in the ambulance or once he has reached your hospital, what do you do for the patient is initially that you would be giving dual antiplatelet therapy. You could be giving aspirin, and along with aspirin, you could be giving ticagrelor. So nowadays, as far as the management of our patients are concerned, they will use the term DAPT. DAPT would mean dual antiplatelet therapy. So this is only a mnemonic. What I'm going to do for the patient is give DAPT, dual antiplatelet therapy. We will compile a list. When do you use dual antiplatelet therapy? But at the moment, I'm just going to say it verbally. We use it for ST elevation MI. We use it in non-ST elevation MI, unstable angina. Three situations, right? DAPT would be useful for STEMI, non-ST elevation MI, unstable angina. Apart from that, even in patients of transient ischemic attack, patients who are having stroke, and even if a person has undergone a stenting in the heart or has undergone coronary artery bypass grafting, then dual antiplatelet therapy would be used. So we are going to use aspirin in these patients initially on the way to the hospital or on reaching the hospital. For anti-ischemia measures, you will be using sublingual nitroglycerin. You can give it a total of 3 times. Do not give nitrates if the systolic blood pressure is going to be less than 90. You very well know the fact that if in any individual you give nitrates and the BP is already low, then the problem in your patient would be development hypertension, because nitrates are anyway very good vasodilators. So you don't want to lose out the blood pressure and compromise the coronary blood flow further. You don't want to compromise the renal circulation further. In spite of giving nitrates 3 times, if you're not having relief, then you could be giving morphine to the patient. Though lots of time, morphine would not be available. So you might have to manage without it as well. But the initial 2 drugs would be highly, highly effective. And as far as oxygen is concerned, we may not require oxygen for all cases. Only if you document that the SPO to the patient is less than 93%, that we can be giving oxygen. Otherwise, even if a patient is not having, let me say, if he's not having anterior MI, he's having inferior MI, inferior MI will involve the right ventricle. Right ventricle involvement will not cause pulmonary edema. It is left ventricle failure that causes pulmonary edema. If you don't have pulmonary edema, there would be no drop in oxygen saturation. So you could be managing the patient on room air as well on the way to the transit to the hospital. So by reading about MOON, in Pharmac, what I find is people are under impression that we start with morphine. Obviously, we don't. It is rather antiplatelet and it is anti-ischemia measures. It is antiplatelet, DAPT, and anti-ischemic measures that must be initiated initially. Oxygen if required, and then if you have given nitrates, 3 times and there is no improvement over a span of 15 minutes, then morphine would be welcome if available. But these are all initial procedures which would help you in stabilization of the patient. Once your patient will reach the hospital, you would also be using beta blocker. Yes, metoprolol. So one more drug that I'm mentioning here is metoprolol. Why metoprolol? Because it reduces oxygen consumption of the heart by decreasing the heart rate. So you should always give metoprolol, but don't give it if the heart rate is already 60. If the heart rate is person is having bradycardia, like after MI he developed heart block. In heart block patient, because heart rate is already low, if you give beta blocker, BP will decrease even further. So before you give nitrates, check the BP. The message is, before you give nitrates, check the BP, and before you give metoprolol, have a look at the heart rate on the multipara display, so that we do not give it to somebody with a bradycardia and he ends up with hypotension subsequently. Metoprolol has been shown to reduce the size of the infarct because it reduces oxygen consumption of the heart. So these are initial steps that would be taken before the patient is taken into the cath lab, and then a balloon angioplasty would be done in the patient, which would be called as primary PCI. And thrombolysis, I told you, should be done within 30 minutes of arrival of the patient into the hospital. Now, the question in the exam said upper limit of thrombolysis. So please understand the concept clearly. When I talk about upper limit of thrombolysis, we are not talking about that door to needle time. Door to needle time means, like, let me just describe it for you. Somebody had MI at 8 a.m. in the morning. An Indian patient might come to you after 3 hours, maybe coming after 6 hours, maybe, let me say, come to you even later, maybe reach up to 12 hours. I mean, the onset of MI, let me say, MI usually occurs in morning hours. No, that's because vasoconstriction in human body is more in the morning hours. So the stress on the heart will be more in the morning hours. You always see, MI is more common in morning hours, stroke is more common in morning hours. Why? Because vasoconstriction is more in the morning hours. So more stress on the heart. Now, the chap had problems at 8 a.m. in the morning. He might come to you at, let me say, 2 p.m. If he comes and reaches your hospital at 2 p.m., you would start, the registration process and start basic treatment that I spoke about. Your objective should be that if you're working in a non-cath lab hospital, you should be able to do thrombolysis. Suppose he came at 2 p.m., you should be able to do thrombolysis by 2:30. Similarly, came at 5 p.m., you should be able to do by, let me say, 5:30. The question was not asking within how much time of the patient coming to the hospital thrombolysis should be started. The question was, what is the upper limit of thrombolysis? I mean, the options in the MCQ were, and I'll just put numbers here, 3 hours, 6 hours, 9 hours, 12 hours. I mean, how long would you be ready to wait before you say, okay, I mean, thrombolysis is not going to work after this much time? There are two concepts that I said. One is patient came at 2, I would try to treat him by 2:30. If he comes at 5, I'll try to treat him within 5 by 5:30. Here I'm talking about the upper limit of thrombolysis. The upper limit of thrombolysis should be answered for STEMI as a huge, huge 12 hours. You will notice that subsequently when I'll be describing the topic of stroke before you, acute ischemic stroke, the window period that I'll be describing will be 4.5 hours. But at this junction, what I'm telling you is a value of 12 hours. So I would like to jot it down. I mean, both the information for acute ischemic stroke, the window period is to be remembered as 4.5 hours. That is going to be discussed in the neuro section subsequently also. But because this upper limit has been asked, so I thought I'll just mention about both these facts. For stroke, it's 4.5. Neurons are more susceptible to hypoxia. Cardiac muscle is able to resist hypoxia for a relatively longer duration. So the upper limit has been defined as 12 hours. And I mean, the query from a lot of young doctors is, sir, what's the big deal? I mean, why are you ready to wait till 12 hours? What's going to happen after 12 hours? Why not 15 hours? You described in a hospital that, okay, we're going to do this procedure up to 12 hours, and patient reached at the 13th hour. And his son is educated, and he says, maybe has a science background, and he says, sir, I saw on the display of your hospital that you were doing thrombolysis within 12 hours. Why we came at the 13th hour, right? They might be coming from periphery. Why not? The point is, what they've documented is thrombolysis has a big side effect. No, you very well know. What is the biggest side effect of thrombolysis? Bleeding. So what they found is, after 12 hours, the side effects are relatively more as compared to the benefit. In medical science, it's all about benefit versus loss. When you go and fight a war, if you're fighting with somebody, if you hit somebody, the guy will hit you back, right? So my point is, one is a benefit. I mean, that guy might be a bully to you, so you're trying to hit at him, but he's going to try and hit you back also. So there would be some contralateral damage. So in medical science also, we always talk about benefit versus the loss. In the first 12 hours, what we've demonstrated is benefit is more than the loss. Whereas after 12 hours, we have documented the side effect of bleeding, or I would say rather even intracranial bleeding incidence goes up. So in those circumstances, though, because the I would say the loss is more than the benefit, so we are not doing this procedure. And at this point of time, I can just test your pharmacology here. And I would like you to prompt it loudly. I know it's a recorded class, but I'm trying to just keep that vibes of a live session here. Can you tell me the antidote for streptokinase toxicity? Just like you guys are comfortable with, if a person is having warfarin toxicity, we might be using vitamin K, or even if required, fresh frozen plasma. If it's gonna be a patient who is having let me say heparin toxicity, protamine sulfate, you all have read about it from pharmac. So can you tell me the antidote for streptokinase toxicity? Yep, guys, I think you would be familiar. We'll be using ECA, that is epsilon amino caproic acid. I'm not writing the full form because you know that from pharmacology. ECA is epsilon amino caproic acid. That would be an antidote to streptokinase toxicity. So they love to ask about, integrate the aspects with the pharmacology, integrate the aspects with physiology, as is the pattern at the moment. So the minimum carry home message from this slide is treatment of choice for STEMI would be given by you as primary percutaneous intervention, though initial drugs can be also asked. And if he says what is the biggest side effect for thrombolysis, it is bleeding. And when would you not do a thrombolysis? Then the exact opposite aspect of this would be thrombolysis is contraindicated in non-ST elevation MI. Why? Because in ST elevation MI, guys, the concept was that this is gonna be a fibrin rich clot. So it is possible that you can destroy it. But in non-ST elevation MI, it has been documented in post-mortem studies. No, we did post-mortem of all those people who had a non-ST elevation MI. There was no ST elevation, there was ST depression with a T wave inversion. In those circumstances, what we found was that the person was having rather a platelet rich thrombus or a clot. And when you are giving him a thrombolytic drug, the side effect was occurring, benefit was not occurring. And that's why I said, I mean, it's always about benefit versus loss. So in non-ST elevation MI, thrombolysis is contraindicated. On one hand, I was praising thrombolysis. I said, I'm going to do it within 30 minutes for a STEMI if I'm working in a non-PCI capable hospital. Now I'm criticizing the same drug because of the benefit versus the loss aspect that I mentioned. So remember the statement, upper limit of treatment of escalation MI by thrombolysis is 12 hours. And thrombolysis is also done in acute ischemic stroke. The upper limit is 4.5 hours. But you're not going to do thrombolysis in brain hemorrhage. I mean, God forbid, if somebody does thrombolysis, brain hemorrhage, the bleeding part will worsen. It will cause deterioration of the patient. And just like you're comfortable with this fact that I'm not going to do thrombolysis in brain hemorrhage or hemorrhagic stroke, I want you guys to be comfortable with the fact that thrombolysis is contraindicated in non-ST elevation myocardial infarction. Now, before we talk about drugs which are used in non-ST elevation MI, I would utilize this time to also talk about the aspect of infarct localization. You see this particular septum, this is the area between the left and the right ventricle, and some part of the left ventricle that I've shown here. This is studied by lead number V1 and V2 in the ECG. On the other hand, the major part of your left ventricle, when this is the left ventricle, a major chunk of your left ventricle is going to be read by lead number V3, V4. So you can treat these leads of the ECG like CCTV cameras. They would be recording various surfaces of the heart. Similarly, some part of your left ventricle that is going towards your axilla, your heart, some part would be facing the axilla also. The CCTV camera or the electrode that's going to be reading that would be V5, V6. Why I said that is because V5, V6 are mainly studying the lateral wall of the heart. So by default, I mean, every time I say lateral wall MI in a patient, which lead am I gonna check out? It's gonna be V5, V6. But when it comes to studying the septum, then it's gonna be the lead number V1, V2. And you see, ECG was invented by a doctor by the name of Einthoven. And when he developed these chest leads, you will notice that almost everything was focused towards studying the left side of the heart. I mean, we are literally giving a step brotherly treatment to the right ventricle. A right ventricle, maybe some part of the right ventricle is being read by lead number V1 also. You can see some part of the right ventricle is being read by lead number V1. But otherwise, if you look at it, most of the electrodes are biased towards reading the left ventricle. So, one, if they just ask you which chest lead, listen to my words carefully. If he says what chest lead is used to study the right ventricle, the word is chest lead. Chest lead numbers are V1 to V6. If it says which chest lead is used to study the right ventricle, your answer would be given as V4R. V for R means that whatever is the position of the lead number V4 on the left hand side, you are gonna invert it and put it on the right hand side. So if the question says chest lead, that is gonna be helpful. And for the chest lead locations per se, you need to refer to physiology component. I mean the position of the leads per se. So V4 diametrically opposite is gonna read the right ventricle. But do you put V4R routinely? No, no. I mean, your technician is not as smart as you guys are. He's not going to dream of the fact that person is having a problem in the right ventricle. So he's not going to deploy V4R. So how do you study the right ventricle is what I explained right in the beginning. I said you need to scan lead number 2, lead number 3 and lead number AVF. It is not AVR. It's not AVR. In fact, I'll just highlight that with a separate color. It is not lead number AVR. It is lead number AVF that is to be scanned to study the right ventricular problem. Now I can just highlight blood vessels in this case, and I'll use a different color to just highlight those blood vessels here. Let us assume that this blood vessel that is coming up is the left anterior descending artery. This is LAD, left anterior descending artery. This could be having a branch like this, that is the septal branch. And then it would be having a branch which would be going laterally, curling around the heart and going posteriorly. This blood vessel that I've currently shown before you is called as left circumflex artery. On the other hand, you can see the main blood vessel that I've shown here. This one is the left anterior descending artery. So the message I want to give to you guys is that suppose God forbid, there is a thrombus in this left anterior descending artery. There's a big clot which is occluding the left anterior descending artery of the patient. Then this clot would be, I mean, because of the necrosis that would be occurring because of this blockage, this would be mainly read by lead number V1 to V4. All these leads V1 to V4 would be studying left anterior descending artery. I mean, the way Einthoven designed these leads was to study the cardiac anatomy from the perspective of blood vessels. So whenever you are going to be having changes in lead number V1 to V4, you're going to talk about the commonest type of MI that we see overall in clinical practice, that is anterior wall MI. And why that is so is because in pathology you study the commonest blood vessel of the heart that is involved by atherosclerosis is LAD. In pathology, they always say commonest blood vessel of the heart. Overall in the body, it is abdominal aorta. Overall in the body, of the commonest blood vessel involved in atherosclerosis is the abdominal aorta, infrarenal. But if he specifically mentions of the heart per se, it's left anterior descending artery. And therefore, because atherosclerosis would be affecting LAD, there would be myocardial infarction of the anterior wall. But on the other hand, if he says lateral wall MI occurring in a person, then it would be the blood vessel that I've just highlighted before you, that is left circumflex artery. On the other hand, if the findings are found only in V1, V2, then it means that the thrombus would have occurred in the septal branch, no? And the thrombus would have contributed to myocardial necrosis. But on the other hand, if there's a separate blood vessel that I'm highlighting, that would be the right coronary artery getting affected, and there's a big thrombus here, then either you need to pick it up by right ventricular MI by putting V4R, but V4R is not routinely put by your technician. He's not going to dream of the fact that the patient is having a inferior MI. So it is lead number 2, 3 and AVF that would do the trick for you. So I just wanted to, with help of this diagram, mention regarding the infarct localization part. The same anatomical diagram is represented here. But what we'll do here is a small quick activity, and I want you guys to do this activity with me, where what I'll mention is a couple of aspects, which is, and try to do this with me. I'll be talking about which blood vessel is involved. I'll be then mentioning regarding which surface of the heart would be involved and which leads of the ECG would you be checking out per se for picking up a particular blood vessel involvement. If it's gonna be, let me say, the involvement of the left circumflex artery, then we have just discussed this would be a lateral surface involvement. So I'm gonna call it a lateral wall MI. And the leads that would help me pick it up would be lead number 1, AVL. 1 and AVL will be by default written in all the inputs that I give to you subsequently, but predominantly V5, V6 are going to be having either a ST elevation or a ST depression with a T-wave inversion, and biomarkers would get deranged. On the other hand, if it's the septal branch that gets involved, then the septal branch involvement would cause a septal myocardial infarction. And in this particular case, it would be lead number 1, AVL, and lead number V1, V2 that would be affected. But if he says that left anterior descending artery is getting involved, then this would be causing anterior wall MI. The findings would be now found in V1 to V4, as I've reiterated in my previous diagram as well. But there is a possibility that he might use the word, and I want you to pay attention to the terminology that I'm writing here before you. I'm writing extensive anterior wall MI. I'm not writing the word plain MI. I'm writing the word extensive anterior wall MI that is occurring in a patient. So we talk about lateral wall MI, septal MI, anterior wall. Extensive word is a prefix in the question. Then don't answer it as left anterior descending artery. Then don't answer it as left anterior descending artery. Your answer would be given as left main coronary artery. It is left main coronary artery, which I would put it like this. This is the main blood vessel that starts from the coronary ostia and then gives the branches which are present or written superiorly. Left main coronary artery, if is involved, the ECG findings would be found in lead number 1, AVL, and V1 to V6. And if you are listening to me carefully here, you will notice that if you add the top three, varieties, then this would be a possibility. I mean, this is going to be a situation where patient may not reach the hospital. He may die in the ambulance or on reaching the hospital. Let's now compare this with if he wants to trouble you with the MCQ talking about posterior wall myocardial infarction. Then the blood vessel that would be involved in posterior wall myocardial infarction would be posterior descending artery. It is posterior descending interventricular branch. Once this blood vessel gets occluded, let's look at what are the findings that we would be getting. When you are going to scan the ECG of this person, you will notice that in V1 to V4, it's posterior wall, right? Damage is in the back, it's not in the front. V1 to V4 will not be having a ST elevation, but will be having a ST depression. If it is posterior descending artery getting involved, posterior wall MI, you would be having, like traditionally we have ST elevation, that would be common type of MI, you would be getting a ST depression. So what are you going to do here is that you will ask your technician to put special leads. The special leads that would be instructed by you in your technician would be V7, V8 and V9. And when you are gonna check out these V7, V8, V9, you're gonna be having ST elevation. What I want you to understand is that in any MCQ, if you are getting this combo given, you are having a ST depression given in V1 to V4 and ST elevation in V7, V8, V9. Both of these things should be given together. The reciprocal, the concept is reciprocal changes. Both should be written in a question for you to answer it as posterior wall myocardial infarction. Otherwise, don't comment on posterior wall MI. I'll say that fact once again. Give me undivided attention and listen to what I'm saying here. Suppose you get a question in the exam in which V1 to V4 is having a ST depression, and there is no information given for V7, V8, V9, or let me say, V7, V8, V9 were put and ST was not showing any changes. If this information is given alone, then your interpretation in this case is that your patient is having a non-ST elevation MI of the anterior wall. Please appreciate the fact that anterior wall was read by V1 to V4. If there's a ST elevation, I'll write STEMI anterior wall. If there's a ST depression, I will write non-ST elevation MI of the anterior wall. Obviously, biomarkers have to be eliminated. So in this case, you will answer which blood vessel is blocked. It is still left anterior descending artery. Remember, I taught you if there is a fibrin-rich clot in the LAD, we would be having a STEMI. On the other hand, if I have a platelet-rich clot, then this would be a non-ST elevation MI in the LAD. So you need to pay attention specifically to the fact. The main learning point is that if you are having a combo of the two findings that I've written in red and green given, that is a ST depression in V1 to V4 and ST elevation V7, V8, V9, answer it as posterior wall. If he just mentions V1 to V4 ST depression, it's a non-ST elevation MI. We usually get tired by the time we reach the bottom of the table. By the time we reach the bottom of the table, we are so fatigued reading this that we are wondering when the hell will this table end. And the examiner knows precisely where the fatigue factor will come in. So when I started with cardiology, showed you ECG, I began with inferior wall MI, because the examiner knows where the fatigue factor would come and where things would start going wrong. So I have already sensitized you to the fact that lead 2 3 AVF would pick up inferior wall MI, and the coronary artery involved here is the right coronary artery. In fact, that was the first information that I mentioned. And if you're noting with me, you can see a very substantially big table has been created where I've described the various coronary circulations with respect to the blood vessels. And out of these table that I have made before you, the minimum that is expected to be known right now. Obviously, you can't remember everything, but the minimum that I expect you to appreciate is one, that do not mess up between anterior wall and extensive anterior wall MI. I mean, this would be a sin. This would be like harakiri, which you study in forensic medicine. The Japanese samurai used to do that, harakiri and kill themselves with a sword. That you just miss out on a word, because majority of questions go wrong, not because of lack of knowledge, but they go wrong because of lack of application. Majority of people, when they are sitting for an exam, the exam's anxiety kicks in, and at the same time, I mean, you are just trying to rush through the question. Okay, this could be a possible answer, so you need to keep on practicing. I mean, persist, as I always say, or I say, keep hammering. I mean, you will see the light at the end of the day, and here the light is differentiation between these and extensive anterior MI. Most people might die on reaching the hospital. Most of the time they might be having a ventricular fibrillation, or they might be having a pulseless ventricular tachycardia, and if there is no defibrillator available, most of these patients would die. If he's not going to ask about this, then he has already asked. Even in your FMG exam, sir, I mean, if you're finding it overbearing, even in the FMG exam, they have given a ECG and they have simply said patient presents with chest pain and chest discomfort and shortness of breath and let me say elevated JVP, and some heart sound findings were given. But the point was mainly to pick up findings in lead number 2 3 AVF, which I've already shown before you. So once you get a hang of this, you are much more comfortable for the current image that I'm showing you. And though traditionally you should always begin by checking out the heart rate, but this is something in your face. I mean, you can see the tombstone pattern. You can see the ST elevation, which is going in upward direction. In fact, there's another term that I want you to remember for tombstone, that would be called as Pardee sign. Both tombstone and Pardee sign would mean the same. And just look at this. I mean, you are having that significant ST elevation present in this particular patient, where in lead number V2, V3, it's also present in V4. It's going up to V5, it's going up to V6. Maybe a bit part of V1 is not involved, but because majority of the anterior leads, including lead number 1, including lead number AVL, and now compare this with lead number 3. There's a reciprocal change occurring. No? For lead number 3, you can see a reciprocal change occurring in the patient. For AVF, again, you can see a AVR also, there's a reciprocal change. No? For the right side, opposite electrical findings would come. ECG is a vectorial analysis. So you would be getting opposite findings in the leads where you are getting a characteristic ST elevation. So this that I have shown here before you would be called as extensive anterior wall myocardial infarction. These patients are at high risk for development of cardiogenic shock. They are at high risk for development of pulmonary edema. In fact, in these patients, there can even be sudden cardiac death. What I mean by sudden, I mean the definition of the word sudden here is a person dies within 1 hour of being either heard, like he talked on the phone to somebody, like this is the old person, 70 years of age, retired person, diabetic, he stays in India and his son stays abroad, and he had a WhatsApp video call with his son. And after 1 or 2 hours, like this man collapsed, and maybe the servant of this person rushed him to the hospital, and from the hospital you giving a call to his son saying that your dad is no more. And I mean, his son is just shocked. I mean, he says, I spoke to my dad 1 hour ago. So sudden cardiac death is within 1 hour of either being seen or heard, like, talked on the phone, not a video call, a routine call, talked with somebody or maybe seen by somebody, and then the person dies a sudden cardiac death. And there could be tachyarrhythmias that we'll be handling subsequently. Either it could be a ventricular fibrillation, or it could be a PVT, not a PSVT. We'll talk about PSVT also. This is pulseless ventricular tachycardia, for which the only way to save this patient would be defibrillation. Obviously, maybe the servant tried to give CPR, but it might be actually too late. So chances of these patients dying because of extensive necrosis in the heart, to develop tachyarrhythmias and develop cardiogenic shock, will be substantially high. And we're going to talk about complications that can occur in these patients as we progress in this discussion. Now, once you get a hang of these two common ECGs, I'm just gonna go back in my slide. Must know information for you. You are not supposed to mess up ever between in. Ideally, I want you to pick up every type of MI, but inferior wall MI and extensive or anterior wall MI per se, I mean, those are like bread and butter kind of MCQs that you should be able to solve. And the next thing on the agenda would be to speak regarding non-ST elevation MI or acute. It's written as NST EMI or it's written as non-ST elevation ACS. ACS matlab acute coronary syndrome. Do not confuse this with. In fact, I'll just use this slide also to mention. He once in the exam used the word acute chest syndrome. I am teaching you acute coronary syndrome. Every time I'm talking about coronary arteries, right? Acute chest syndrome. Acute chest syndrome is what you read with sickle cell anemia. Remember, in sickle cell anemia, there is sickling episodes and the RBCs become very sticky. And because the RBCs are sticky, they will occlude the coronary microcirculation, and that can explain the chest pain in these patients of sickle cell anemia. It is sticky red blood cells which are the problem here. In acute coronary syndrome, problem is atherosclerosis. In acute coronary syndrome, the problem is atherosclerosis, but in acute chest syndrome, it's gonna be sticky RBCs of sickle cell anemia, which are the troublemakers. Now, when you have a non-ST elevation MI acute coronary syndrome, it might be also written in MCQs as a /UA. UA means unstable angina. So just like, you read a term COPD, and then you have two component emphysema, chronic bronchitis. Similarly, there could be non-ST elevation MI versus unstable angina. I'll tell you the differences between the two also, but at the moment I just want you to remember, like in COPD as a broad term, you read about chronic bronchitis emphysema. Similarly, these two terms are also to be understood in a same fashion. Now let me just explain what is the fundamental difference between the two. When it comes to unstable angina, what happened was a plaque fissure. Remember, I spoke about plaque fissure. There's a tear in the atherosclerotic plaque, and then there's a thrombus formation. So in green, you can see that there is a thrombus formation in the coronary artery. But then in human body, you have a clotting system, you have an anti-clotting system. Anti-clotting system is like protein C, protein S, antithrombin 3. So anti-clotting system, what it has done in this case is that it has started the inbuilt anti-clotting system of the human body has started breaking these clots into pieces. And if the clots will break into pieces, then these clots will go and block these small branches, these perforators, these small branches which I have now shown here before you. They are called as perforators. So the word I want you to remember for unstable angina, every time you read the word unstable angina, your thought process should be that the thrombus did get formed in the artery, but it is not causing a complete occlusion of the artery. In myocardial infarction, there's a thrombus occluding the artery. It could be two varieties, fibrin-rich clot or a platelet-rich clot, right? But in unstable angina, what happened was, luckily, the clot got fragmented and pieces of this clot are getting distributed and are causing blockage of perforators, which will explain the chest pain in this patient. Just to see that you and me are on the same frequency, just think logically and tell me that if a doctor will do thrombolysis in this case, if you start giving streptokinase or you start giving L-teplase to this patient, when you are gonna destroy, already the thrombus is disintegrated, no? If you start giving a thrombolytic drug to this patient, it will break this clot into further small pieces and it will cause deterioration of the patient. What I am trying to explain to you is that why did I say earlier thrombolysis is contraindicated in patients of unstable angina or non-ST elevation MI? That's primarily because whenever you read the word unstable angina, your thought process as a doctor should be what is getting occluded, perforators. By what? Pieces of the small clots which are getting fragmented already. So since the clot is already in the process of fragmentation, if you give thrombolysis, it will break the clot into further pieces which will get further disseminated and worsen the patient. Thrombolysis is never done in unstable angina. It is atheroembolism as a word. The minimum carry home message here is, if you get this word right, atheroembolism, clot formation, fragmentation, pieces causing blockage of perforators. This would, I mean, be a thought process of yours every time you read about unstable angina in a patient and thrombolysis is not done. Similarly, for non-ST elevation MI, I've told you this would be a platelet-rich clot. So again, thrombolysis is contraindicated, but thrombolysis is definitely indicated within 30 minutes of patient's arrival to the hospital. But upper limit, he had chest pain at 8 a.m. So you might be treating thrombolysis or doing thrombolysis up to a 12-hour period. So do remember these facts here. Where would you be saying it contraindicated and where would you be saying it is, yes, this is correct? I mean, thrombolysis would be done only in ST elevation MI. Now, once we get this facts right, the next agenda of mine would be to talk about drugs which are useful for non-ST elevation MI, and a couple of updates from the 21st edition of Harrison, which I've tried to incorporate here as well. So let's look at what is the drug strategy that you will be deploying. And first and the foremost thing would be to manage the ischemia component. If the chap is having chest pain, in non-ST elevation MI, the ECG would look like this. I mean, if you're wondering how the ECG would look like, this is going to be, let me say, having a ST depression with a T-wave inversion. And the tropi of this patient might be showing a doubling, tripling, which was written as 99 centile of the upper reference limits. This finding may be present in, let me say, lead number V1, V4. So my clinical diagnosis in this case is this is a non-ST elevation MI of the anterior wall. The first and the foremost thing I need to do in this particular chap is anti-ischemia measure. The anti-ischemia measure would mean that I'll be giving sublingual nitrates to this patient, or if I have a buccal spray, great. Apart from nitrates, another anti-ischemia measure that I'll be using here is a beta blocker. Remember when I was describing ST elevation MI, I was talking about a beta blocker, and now I'm talking about beta blocker even in non-ST elevation MI. Why? Because this beta blocker will decrease the heart rate, decrease the oxygen consumption of the heart, and cause reduction in the hypoxia component. I mean, everything that we're doing is for damage control. Now, suppose you have given nitrates 3 times at a gap of 5 minutes and you ensure that the BP of the patient is remaining more than 90 and there is no improvement, then you would be using morphine. And as I told you, I mean, practically speaking, in majority of our hospitals, government places, morphine may not be available. So it's mainly management with nitrates and metoprolol that you will have to do. But yes, you have morphine, and if not morphine, then I mean, off-label multiple drugs have been tried. But then why morphine is recommended is not only for chest pain, no? I mean, morphine is given not only for chest pain, morphine reduces pulmonary edema also. If you read pharmacology, why do you give morphine in MI is not only for chest pain. Morphine also reduces pulmonary edema. It causes shunting of blood from pulmonary to systemic circuit. So it has its own advantage, though there are disadvantages also. Like it can stimulate vagus nerve. So person might have vomiting sensation. A person might have reverse peristalsis due to vagotonic action of morphine. So do look at the heart rate before you decide to administer morphine to the patient. And nitrates and metoprolol will be the mainstay initially when you manage the patient from the anti-ischemia perspective. And similarly, you will be using dual antiplatelet therapy. From dual antiplatelet therapy, what are the drugs that you would be using? So the name of the drugs can be remembered as ACPT. In ACPT, aspirin will obviously be used. You can use like a 325 milligram loading dose followed by maintenance 75. Along with aspirin, you could be using clopidogrel. But lots of time, clopidogrel may not show good results in especially Indian patients. So there are a couple of other antiplatelet drugs that they love to ask. You will notice that whenever they are asking you pharmacology of cardiovascular system, they love to ask about antiplatelet drugs. So you have to read about P2Y12 inhibitors. The P2Y12 inhibitors which can be used orally are prasugrel, or we can be using ticagrelor. These are oral antiplatelet drugs that would be useful for management of the patient. In majority of the hospitals nowadays, the dual antiplatelet therapy for non-ST elevation MI which is being used is aspirin with ticagrelor. Obviously, the other ones that I'm saying, it's not that they are not useful. It's just the fact that all of them are associated with bleeding. All of them have benefit. All of them have the loss of bleeding. So aspirin and ticagrelor as a dual antiplatelet therapy is what is being favored now. So I've told you 4 drugs till now for management of these patients. Morphine is anyway for chest pain, so no big deal. Anybody and everybody can answer that. What you need to remember for the exam would be one, nitrates as anti-ischemia measure and beta blockers, never to be forgotten. Then is antiplatelet drugs, that would be DAPT. The DAPT, at least two to be remembered, are aspirin and ticagrelor, which would be given orally to the patient. Then in these patients of non-ST elevation MI also we are doing PCI. Initially, I manage the patient medically, then I'll be doing a PCI in the patient, that would be called as a delayed PCI. In ST elevation MI, I always will use the word per se primary percutaneous coronary intervention. Primary percutaneous coronary intervention. But when it comes to non-ST elevation MI, you will read the word delayed percutaneous coronary intervention. We are managing with drugs most of the time. Now, when a person is scheduled for percutaneous coronary intervention, when a non-ST elevation MI is also being taken for a PCI, then we might be using intravenous antiplatelet drugs, and this is where they would love to test your pharmacology component here, that you have to know regarding cangrelor, or they would love to talk about eptifibatide. So if you have studied about these drugs in pharmacology, great. Otherwise, do brush them up. I know you have read about them. It's just that brushing them up from the pharmacological component would always be recommended. So I have increased your vocabulary for non-ST elevation MI. Let's do a quick recap. I have talked about anti-ischemia drugs, that is NMB. DAPT is pretty standard, aspirin, ticagrelor, and if the person is gonna be taken for PCI, then anyone, obviously not all of them, but any one of these antiplatelet drugs can be used. Like lots of time nowadays, it is eptifibatide or tirofiban which is being used. Along with this, we will also be using parenteral anticoagulation. Why that is so is because I told you that this would be a clot which is a combination of platelet and clotting factors. So this is not a fibrin-rich clot, but it is rich in platelets. So I used antiplatelet drugs, not only oral ones, but IV ones also before I decided to do a PCI. And I'll get rid of the thrombus in the coronary artery. But parenteral anticoagulation that can be used here can be low molecular weight heparin. This low molecular weight heparin molecule that would be used would be enoxaparin. So let's just mention the drugs which are used here. It is NNB initially. Then would be DAPT, which is relatively easy for you to remember. If he talks about PCI, then planning a PCI for the patient, if it's not possible, like in government hospitals, we may not have a cath lab. Or like you might be posted at a periphery where this facility may not be available. So no role of antiplatelet drugs IV then. And then parenteral anticoagulation would be enoxaparin. So these are drugs which are useful for management of non-ST elevation myocardial infarction. And why it is written as a slash? Because in both of these conditions, unstable angina also there might be ST depression. In unstable angina also there is ST depression. In non-ST elevation MI also there is ST depression. Because both are having same ECG findings. That is why they're written as a slash. Now, what is the difference? The difference is that biomarkers will be usually normal in unstable angina. Why they are normal is most of the time because perforators, the smaller blood vessels are getting involved. So the necrosis may not be sufficient enough to cause a doubling, tripling. Remember I told you that for MI diagnosis, you need a doubling, tripling. The fundamental difference between the two terms is that cardiac biomarkers are normal in unstable angina, but they are doubled in non-ST elevation MI. If you're having difficulty in remembering this, let me just give you a quick hack to remember this information. So let me just jot it down here before you. Whenever you write the word ACS, acute coronary syndrome, there are three differentials. One would be STEMI. Please make a table by yourself at this point of time and follow my words. It will just take 1 minute of your time, 3x2 table, and you would be done handling the critical aspect of MCQ right now. In the exam, what they do is they waste your time by giving you ECG. They first waste your time by giving clinical findings. They'll give you vitals, Levine sign, shortness of breath, pulmonary edema, elevated JVP, like that. And then he is going to talk about ECG and the tropi findings. So if you're having a ST elevation, convex in the upward direction, as I told you, no issues, and doubling or tropi or upper reference limit, 99 centile of upper reference limit, cool. If it is going to be rather ST normal or ST depression with doubling or tropi, then it is non-ST elevation MI. But suppose you get a question in which there is ST normal or depression, but biomarker is given to be normal. Why? Because perforator, ultra small blood vessels were getting involved. So necrosis will still happen. Necrosis will still happen, but the kit of ours is not sensitive enough. It picks up when there's a doubling, tripling occurring. It picks up when there's a doubling, tripling happening. It may not be able to pick up, so the values might turn out to be normal. So when you are reading a question of Levine sign, your brain should be clicking with respect to these three differentials that you should be aware of. And what I mentioned next is called as prinzmetal angina. Prinzmetal angina is not a component of acute coronary syndrome. It is being discussed outside the table here just to sensitize you to the fact that even in this case, the question will mention regarding chest pain. The chest pain will be given at rest only, but there will be some fundamental differences. Now listen to the differences here. In majority of questions of acute coronary syndrome, the question will describe a male, smoker, hypertensive, diabetes mellitus, like that risk factors will be given. But this question will begin with a female patient. You very well know heart disease is more in males as compared to females. I mean, females are also affected. It's not that, but then men usually tend to get affected more than women. When question begins with a female patient chest pain at rest, the question also talks about chest pain being more in the morning hours. Now, why that is so is because prinzmetal angina is related to vasospasm, and vasospasm in the body is more in the morning hours. The question might even mention a seasonal predilection, that the chest pain episodes are more common in the winter season. Well, all chest pain episodes are more common in winter season, so I'm not saying that this history is very peculiar for prinzmetal angina, but somehow what I want to draw your attention to the fact that there is vasospasm present in this condition. There is vasospasm of the main coronary artery. The question might even mention past medical history of this patient. She says, doctor, whenever I put my hands in cold water, like she stays in a foreign country, she went out without wearing gloves, and she says my fingertips start changing color. Fingertips start changing color. Fingertips would become white, then blue and red. Now you very well know the sequence. I mean, that's very primitive data, but Raynaud's phenomenon is what may be described, the fingertips changing color to white, blue and red. That would be Raynaud's phenomenon as a manifestation occurring. Raynaud's phenomenon is also vasospastic disorder, no? So this vasospastic disorder can coexist with prinzmetal angina, and when he gives you this history, then he might surprise you by saying that the ECG of this patient is showing ST elevation. Guys, this is the only angina which is having ST elevation. All anginas, either ST is normal or there is a depression. All anginas either have a all anginas either have a ST normal or have a depression. This is the only angina which is having a ST elevation. So the alternative term for this would be variant angina. But even in this condition, when you want to check out the biomarkers, because this is spasm of the coronary artery, spasm is not going to cause necrosis. It's not going to cause death of the cardiac muscles. So biomarkers will be normal. So when you read the question, begins with the gender female, talks about seasonal predilection, diurnal variation, talks about past medical history of vasospasm, but then shocks you by saying ST elevation and says tropa is normal, then this is not myocardial infarction. This would be prinzmetal angina. And for this condition, in emergency scenario, you will obviously be using nitrates. But to prevent such episodes from occurring, the pharmacologist would have talked about calcium channel blocker, amlodipine being used. We will advise these patients to take amlodipine. The advantage amlodipine is it will prevent the spasm that would be occurring in this patient. I mentioned this condition because even this condition tends to have a ST elevation present, but this I would rate as an important slide, because every time they give a question related to chest pain, your job would be to differentiate between the conditions that I have highlighted here before you. Next on the agenda would be to talk about the various types of MI. Now, I've already described MI to you with respect to the surface of the heart involved, but this time we'll be talking about it from the perspective of etiology. So whenever you read about type 1 myocardial infarction, this would be primarily because of the thrombus which is occurring in the coronary artery, and the reason for this could be atherosclerotic lesion or atherosclerotic plaque tear, which is fairly easy to understand. But if he talks about type 2 myocardial infarction, then this would be primarily because of mismatch between the demand or supply. Let me say a young guy went to a rave party and he started doing drugs. Because he was super excited, he took overdosage of cocaine, and once he does overdosage of cocaine, cocaine is a very powerful vasoconstrictor. It can compromise the blood supply to the heart to the level that this person could die also. So we do read about rave party deaths due to cocaine overdosage. Or for that matter of fact, it could be a patient with severe anemia, Now, this person will be having a decreased oxyhemoglobin or oxygen carrying capacity. So the supply to the heart is lesser. I mean, the coronary blood flow per se is okay, but because the delivery of oxygen is compromised, therefore there could be MI occurring in the patient. But whenever you read about type 3 myocardial infarction, this would be associated with sudden death in a patient even before the sample for biomarkers could be taken. We are making a diagnosis of MI in this patient primarily on the basis of two things. That is, one, clinical features, that he had the traditional Levine sign, excessive sweating, maybe a pink frothy sputum due to pulmonary edema thanks to the left ventricular failure that he developed due to anterior MI, and that resulted in sudden cardiac death. Or it could be tachyarrhythmias which could occur after MI could be like ventricular fibrillation or pulseless ventricular tachycardia. And just to make it interactive, can you tell me bradyarrhythmia which occurs after MI and can cause sudden death? Just like you guys are comfortable with ventricular fibrillation, tachyarrhythmia, the query, and I'm giving you a breather, I'm giving you opportunity to think, is which bradyarrhythmia that occurs after MI. I mean, there's so many bradyarrhythmias which occurs after MI and can be so dangerous that the person might die. Well, your answer would be Mobitz to heart block, where there would be a sudden drop in the heart rate of the patient and therefore the cardiac output will fall. The only way to save the life of this patient is not atropine. I mean, you will give atropine, that's okay. And at this moment, I can also say that earlier the dose of atropine was 0.5 milligram. But currently the dose of atropine in American Heart Association guidelines has been changed to 1 milligram. And earlier we used to give it 0.5 milligram and it could be given total of 6 times. But according to the American Heart Association guidelines, AHA 2020 CPR guidelines, basic life support guidelines, it's now total of 3 times that it can be given. But the main thing that you will be doing in this patient would be a TCP, that is a transcutaneous pacemaker, which would be deployed, or I can just say the word temporary pacing. And well, if we don't have the facilities for this, the person might expire. Then we have type 4A myocardial infarction. So we are having two subsets here, 4A and 4B. First of all, I'll mention the MCQ information here that for type 4A myocardial infarction, the values of troponin I could be jumping up by as much as 5 times of the normal upper reference limit. So that's a MCQ statement. Before I go into the etiology of 4A and 4B, I want to mention regarding type 5 myocardial infarction. Etiology is still pending, remember, for 4A and 4B. For type 5 myocardial infarction, you need to remember up to 10 times the values of troponin I can be elevated. So we have this, I would say, a classification with respect to the etiology behind development of MI that is being talked about. So let's look at type 4A myocardial infarction. This occurs primarily after, this 4A per se occurs primarily after a percutaneous coronary intervention or related to percutaneous coronary intervention. You see, after all, you're deploying a balloon in a coronary artery to open up a thrombus, but it's a foreign body. So there is a possibility that post-procedure, the intimal damage that might occur, mainly because of the balloon deployment, can trigger a development of MI in the patient. And when it comes to type 4B, then the point, especially with respect to type 4B myocardial infarction, the concept to be understood is that this is mainly because there was a stent that was put. Now, the good news is the stent will prevent the redevelopment of atherosclerosis, but then stent is after all still metal, or I can say it's a foreign material in the blood vessel. It's not supposed to be present where it is actually present. So there is a possibility of a complication which is called as latent stent thrombosis, and you do read about such instances, or you do read about, or in fact, in your hospital practice, you come across people who would be saying that my dad had got a stent deployed maybe 5 years, 10 years ago, and then in spite of getting the stenting done, he developed the MI. So that was latent stent thrombosis. And when it comes to type 5 myocardial infarction, it's going to be mainly related to coronary artery bypass grafting, CABG. And the query in the mind of most of the people is, sir, CABG we do in triple vessel disease and it's supposed to cause revascularization of the heart. So how is it possible that somebody can develop MI post CABG? Well, I can give two explanations for it, and that's just for understanding purposes. One is that if there's a lot of bleeding at the time of surgery, you see, after all, when you are doing a bypass surgery, you are, putting a bypass with respect to either the internal mammary artery or the radial artery, which is going to be bypassing the physical obstruction. So they can be bleeding, and because of the bleeding, a novice or I would say a relatively young cardiothoracic surgeon might get a little panicky, and he might put clamps. And he might put clamps at the area where the coronary ostia are present, and that might cut off the blood supply of the heart, especially the left main coronary artery. And the bad news is this could trigger a MI on the table. I mean, very unfortunate. Or for that matter of fact, whatever anastomosis that has been done, that anastomosis would definitely mean some connections have been established. So at the time where the anastomosis has been created, we are after all going in for vascular surgery. We are putting some sutures. So even that would be foreign material, and that can trigger a thrombus formation at the site where the anastomosis was done. So this would be etiological, I would say, classification with respect to types of MI that I've discussed with you. And the minimum carry home message for you guys is at least 2 points here. That is, a jump of at least 5 times can be seen with type 4A, and with type 5 MI you don't have a 5 times. That's how you remember it. With type 4A, a 5 time. But with type 5 myocardial infarction, it's not a 5-time hike. It is up to, cross 10 means up to a 10 times elevation of the value of troponin I. So these are the main messages. When you go through the questions of the previous years, you will come across these values that have been asked. Now, once we are done with this topic of coronary artery disease, our next focus would be to mainly talk about aspects related to the ECG. In fact, we have talked about ECG even in myocardial infarction, but this time I'll be a little more traditional. And the first thing that I'll teach you here is how to focus on the heart rate. Well, the formula would be 300 divided by the RR interval. That's the distance between the R and the R waves. I would suggest you to count the large squares here, though we have formulas for small squares also, but it's relatively easier and faster in the exam. Like if you focus on the inferior most ECG, I'll just zoom it in, then you can see that the number of large squares present here is only 1. So mathematically 300 divided by 1 would be a heart rate very, very fast of 300. But superiorly, where I've done the marking at the moment, there would be 2 large squares. So the heart rate of this patient would be approximately 150 beats per minute. Now, what is the rhythm that we are anticipating will be discussed subsequently. But at the moment, I'm just trying to focus on the RR interval. And you can see that the heart rate of the patient has now dropped to 100 beats per minute. That would be upper limit of normal. But as we progress, this is 4 large squares, and every time I will talk about ECG, I will always be talking about the small squares. I will always be focusing about the small squares. The only time that I am requesting you to focus on the large squares is only with respect to the heart rate, and I'll repeat this statement again. With respect to ECG, everything that we're going to discuss, the P wave duration, PR interval, QRS duration, QT, everything is gonna be with respect to small squares. But with respect to the large squares, it's primarily gonna be the heart rate component. And as we go up higher, you can see that the number of large squares is increasing. So the heart rate in this particular case drops to the lower side of normal. That would be 60. And well, why that is important is because 2 numbers are important here. The numbers which are important here are 35. What I mean by 35 is that if you get a question in which the number of large squares between R and R interval is gonna be at least more than 5, the word is more than 5, it would mean bradycardia, heart rate less than 60. And suppose it is less than 3, 3 is gonna be 100. If it's less than 3, it could be 2.5, maybe it could be 2. That would mean tachycardia in the patient. So the first and the foremost message is, and let me just complete it for the sake of record. I mean, this time you can see that I have put up 6 large squares there. So the heart rate will drop even further. This particular gentleman could be maybe a marathon runner. I mean, lots of time physiologically, you might be getting heart rate of 50, and these people might actually be very fit in a sense that this guy is a marathon runner, and he might be having is a high vagal tone, and this high vagal tone could be explaining the bradycardia component. So high vagal tone explains the bradycardia component, but at the same instance, because I have talked about inferior wall MI, I would like to add one point here, which is the fact that in inferior wall MI, as I told you, it is the right ventricle that is involved. Now, vagus nerve in the heart, and listen to this fact carefully. Vagus nerve in the heart innervates the SA node and the AV node. You very well know that. We have a AV nodal delay of 0.1 second. That's mainly due to the vagal discharge per se. So my message is that vagus innervates obviously the conduction system, but vagus nerve also innervates the wall of the right ventricle, because it innervates the wall of the right ventricle. If the right ventricle wall will be damaged, there would be irritation of the vagus nerve, and this will explain why in a question of inferior wall MI where you read findings in lead 2-3 AVF, you might even notice vitals talking about bradycardia, and at the same time, because vagus nerve is going to be irritated, it will cause reverse peristalsis, and this reverse peristalsis will contribute to vomiting in the patient. And in inferior wall MI, because the right ventricle is just situated above the diaphragm, and it will irritate the diaphragm also. So irritation of the diaphragm can also result in development of hiccups in the patient. So I just want to highlight this fact that in no other variety of myocardial infarction are you gonna read about GI complaints. Every time I've talked about shortness of breath and chest pain or pink frothy sputum due to maybe left ventricular failure, but the only time I am talking about GI complaints is with respect to inferior wall MI. So that's another hack that would help you solve it. And why I mentioned this primarily because the bradycardiac part just came up. This could be due to high vagal tone in a marathon runner, but with respect to inferior wall MI also, you could be having bradycardia with a very severe hypotension. And he might say that what could you do for the management of this hypotension? Now listen to this fact very carefully, because there are two concepts which are going on simultaneously. One is evaluation of the heart rate on the ECG, but just now I have sensitized you to the fact that inferior wall MI will be having hypotension. Why? Because of bradycardia. And for the management of this hypotension, he will ask you, what will you do? And your answer would be IV fluids, which is very shocking because traditionally in MI, we don't give IV fluids. Suppose somebody is having anterior wall MI, that means left ventricular failure, that means pulmonary edema. In a pulmonary edema patient, we are never ever gonna give IV fluids. But one MI where you would be giving IV fluids, to get the BP of the patient at least to a respectable value of 90 approximately to maintain the perfusion of the vital organs is inferior wall myocardial infarction. Then in this patient, because there's a bradycardia, you might even have to go in for either atropine, and if atropine will not work, even temporary pacing may be required in these patients. So we will be talking about bradyarrhythmia subsequently, but at the moment, the learning points for us on this slide are: one, from the heart rate perspective, I want you to remember the number 35. What you've just learned is that if the RR interval is less than 3 large square, in fact, let me just write the word LS also so that the visual memory part improves. If it is less than 3 large square difference between the R and the R waves, this would mean that the person is having a tachycardia. And if it's going to be less than 5 large squares, it would mean that the person is having a bradycardia. So that's one of the messages that you must do. And which lead would you look, for checking out the heart rate? Then in a 12 lead ECG, you will always be having lead 2 given right at the bottom once again. Normally you have 1, 2, 3. And then lead 2 would be again given at the bottom, which we can call as a rhythm strip, and would help you in calculating the heart rate of the patient. And the same thing is also reflected inferiorly, as you can see, with different colors. Though I put numbers there, you can visually have a representation with respect to the fact that the variation of the RR interval can be helping, especially with respect to large squares, would help you determine the heart rate of the patient. Now, once that is done, we have a look at a ECG that actually came in the exam, and my students did what I have always asked them to do, that is count the heart rate and count the RR interval initially. Now, this is what they told me. They said, sir, as you had told, we counted the number of large squares between R and R, and one of the students said that I noticed that it was 3 large squares, which meant a heart rate of 100. But then he said, sir, something very surprising was happening, that in the subsequent, when I, scanned the ECG from left to right, I noticed that the RR interval was changing. The RR interval of the patient must be counted at least twice, or at least I would say thrice, because lots of time they are going to give you in the exam information with respect to variable RR interval. Whenever they give you information with respect to variable RR interval, there are certain possibilities which are to be considered. And I want to bring to your notice that the heart rate of this patient has suddenly changed from 100 to 75 per minute. So what is causing it? This is not a tachyarrhythmia, because for tachyarrhythmia, the heart rate should be more than 100. So what I'm going to do in this ECG is now have a look at, am I having a normal sinus rhythm, which means that after a P wave, the QRS complex should be present. Now, when I look at this ECG, you very well are able to decipher the P wave, and then subsequently the PR interval also. Then there's a small negative deflection, the Q wave or QRS complex can be seen. So the patient is in normal sinus rhythm, but in spite of that, the heart rate of this patient is varying. This presentation that I've just made before you was asked even in the FMG exam. This presentation where you are not having a tachyarrhythmia because heart rate is normal, but it is still varying, is called as sinus arrhythmia. And well, why do you have this sinus arrhythmia is because of the variation with respect to the vagal tone. Our vagal tone always exhibits a variation, and this is with respect to the phases of respiration. I want to highlight this fact that with respect to inspiration and expiration, our heart rate can fluctuate. So this particular ECG where you can pick up normal sinus rhythm, there is a P wave present, would be called as sinus arrhythmia. This question has also discussed in the app. It's also been present on social media, on YouTube, etc., where I keep on discussing these various questions. But now, what I want to draw to your attention is, and at the moment, even if you are, in your notes, indulged in your notes and listening to me, just compare the ECG that I was showing earlier with the one on the board right now. Even at this point of time, you can notice that the heart rate of the patient is fast. I mean, it has suddenly jumped up to, let me say, 150 beats per minute. And then something very shocking happens thanks to the vagus nerve, that it gets to about 3.5 large squares, which would mean that it is jumping to slightly less than 100. When mathematically speaking, I'm saying that the heart rate of the patient just few milliseconds back was 150. Now it has jumped to less than 100. There is a variation in the RR interval of this patient to the level that if I extrapolate this to approximately, let me say, 5 large squares, then the heart rate of the patient is decreasing down to 60. So we are having a acceleration, a super acceleration, deceleration to 100, then heart rate going down to 60, and then maybe again an acceleration. And I'm going to check out the P waves, and I'm not noticing a standard P wave which should be present the way it should be. Rather, what I'm noticing here is a twitching which is occurring right before the QRS complex in the patient. There is absence of P wave. Now, before I comment, and I think most of you would have guessed the answer by this point of time, but if you go back to the previous ECG that I showed you, one, I mentioned the fact that there was no tachycardia present. The heart rate of the patient was usually in the range of 100, went down to 75 and never went beyond that. So, and P wave was also present. So I was calling it a sinus arrhythmia. But for this particular ECG, which is currently on the board, because there is absence of P wave, undulation around the baseline, QRS complexes are coming. But then the bad news is the atria are twitching at this point of time. So I'm going to call it atrial fibrillation. So you have at this moment learned regarding two situations where there could be a variable RR interval, sinus arrhythmia and atrial fibrillation. And even if you don't get into the heart rate fact of whether it's going to be a tachycardia versus a normal heart rate, the main crux of the discussion is the patient in normal sinus rhythm? Is a P wave present before every QRS complex? Then in atrial fibrillation, that is not the case. The atria twitching, so there's a big problem coming up subsequently, which is going to be clots that would be developing in the left atrial appendage of this patient. And if these clots land up into the brain, they could be stroke. If they land up into the superior mesenteric or the inferior mesenteric artery, he could have a infarction of the bowel. So you might be having lower GI bleeding and very severe abdominal pain in this patient. And if it's not identified, you might even have gangrene of the intestine. So this is one of the very common arrhythmias that we get in the exam. In fact, atrial fibrillation is overall the most common sustained arrhythmia. MCQ wise, this is the most common sustained arrhythmia. which is encountered in clinical practice. Whenever you read regarding most common sustained arrhythmia, it is atrial fibrillation. Vedri says most common sustained arrhythmia even in hypertrophic cardiomyopathy. You see, in hypertrophic cardiomyopathy, we have sudden death due to ventricular fibrillation. Mark my words there. I said sudden death in hypertrophic cardiomyopathy is ventricular fibrillation. But if you use this word sustained arrhythmia in hypertrophic cardiomyopathy, the answer is still atrial fibrillation. Even if he says what is the commonest sustained arrhythmia in hypertension patients, or if he says which is the commonest one in geriatric age group patients, in all of these situations, the commonest arrhythmia overall in clinical practice is what I have just shown here before you, where you would be having a variable RR interval once again, but there is absence of the P waves in the patient, and lots of time to describe the physical finding of this patient, he might even use the word irregularly irregular pulse. It will take me a few seconds to write it, but then I think it's worth its weight in the exam. Irregularly irregular pulse is a very good way to pick up atrial fibrillation on clinical grounds. I mean, he might give you a ECG, he might give you the clinical details also. So if he says irregularly irregular pulse, then you should be bang on target and identify atrial fibrillation as the cause. And most of the time, the questions that would be given to you where irregularly irregular pulse will be given would be either questions of stroke, or for that matter of fact, mesenteric insufficiency, which could contribute to hematochezia, severe abdominal pain, and then a gangrene of the gut because of the obstruction of either the superior mesenteric or inferior mesenteric artery, or even both can be involved, because there could be not one but multiple clots developing in the left atrial appendage of the patient. Now, I'll just go back to that question once again. This was the language of the question that actually came in the exam, that 18-year-old lady with recurrent infections of the respiratory tract, and she was having, I mean, the theory that was given was a distraction. It was just that you had to go about evaluating the RR interval of this patient, and we were noticing that the RR interval of this patient was showing a variation. The heart rate of this patient was within normal limits. So a lot of people thought of fancy answers like Wolff-Parkinson-White syndrome. I will be giving you or describing the ECG of WPW also, but always think about common things first. Always think about common things first. So sinus arrhythmia is what is to be answered in this particular case, and atrial fibrillation can be, I mean, a big distraction. In fact, a lot of people answered WPW and a lot of people answered atrial fibrillation, but then for atrial fibrillation is that there should be absence of P wave, which can be visualized in this particular case. Now, I will be describing even atrial flutter. So atrial flutter, still time to come. Hold on for that. And so would be Wolff-Parkinson-White syndrome. Two conditions of variable RR interval is what I have explained. The third condition having a variable RR interval will also be discussed here. I'm saying the name at the moment because at the moment I just want to focus on atrial fibrillation technical details. But the third condition where you have a variable RR interval is multifocal atrial tachycardia. I'll just say it verbally, I'll write it down subsequently. There are three situations where I've taught you variable RR interval at this moment with respect to sinus arrhythmia, then atrial fibrillation and MAT, which is still to come. Now let's focus on the aspects with respect to atrial fibrillation. This would be a sustained arrhythmia, and lots of time the questions on atrial fibrillation might even begin by describing an alcoholic patient, because you know that consumption of alcohol on long-term basis contributes to dilated cardiomyopathy, and that explains the wet beriberi component. But because there is a structural damage to the heart, because of structural damage in the heart, he might say that this alcoholic, he went to a party where free alcohol was available. And because it was free, like all Indians, he started doing binge drinking. And following post binge drinking, he just collapsed, and everybody thought he was intoxicated, and that is why he crashed. But when he was taken to the hospital, the BP was very low, and when the doctor checked out the pulse of this guy, it was a irregular pulse. Even the ECG was showing the characteristic feature that I had shown earlier to you. This description that I have given to you once again for atrial fibrillation, which is due to structural damage to the heart, is called as holiday heart syndrome. Earlier, I was talking about sudden death in MI due to ventricular fibrillation, ventricular tachycardia, morbid to heart block. But at the moment, I'm talking about sudden cardiac death with respect to holiday heart syndrome, which would be alcoholic post binge drinking. And what's happening in this guy post binge drinking is that post binge drinking, the vagus nerve is innervated. And vagus nerve is the one which actually controls the impulses, the speed with which they are able to travel across the heart. Once the vagal discharge is inhibited, the ectopic foci which will develop in atrial fibrillation will make the heart beat so fast that there would be a decrease in the cardiac output. In physiology, they teach you that tachycardia causes an increase in blood pressure. In physiology, they always teach you that increase in heart rate results in increase of blood pressure. But what I am teaching you is always ulta. Every time I'm talking about tachyarrhythmia, I'm saying that the BP is crashing. So I get a query from a lot of people saying, how is that possible? So what I'm saying is when the heart is beating disproportionately fast, so that's why I put up the word pathological tachycardia. If the heart is beating disproportionately fast, the time available for the heart to relax will be lesser. And if the time available for the heart to relax will be lesser, the filling of blood in the heart will also be lesser, and the filling component is compromised. Therefore, the end diastolic volume will also be lesser. No, if the heart is not gonna be able to relax properly, the input is less, the output will also be less, and this will be decreasing the stroke volume of the heart of this patient. So one message I just want to bring across before I focus on more tachyarrhythmias is that all of them result in crashing of blood pressure of a patient, and these are some situations which would help you pick up, like the visual cues of words that would be present in a question and would help you understand or identify especially atrial fibrillation. The biggest problem with these patients would be development of clots. So what we are gonna do for these patients is use the RACE protocol. Let's focus on this mnemonic RACE. First priority would be to go in for rate control, because anyway, if the heart is beating faster, I wanna put on the brakes so that the cardiac output can stabilize. For rate control in these patients, we can be using a short acting beta blocker, that is esmolol. If esmolol is not in the options, we could also be using verapamil. This would be a calcium channel blocker. This will act on the AV node and slows the impulses which are traveling through the AV node. The impulses are coming not from the SA node in these patients, but from ectopic foci in the left atria. And why these abnormal foci were created? Structural damage to the heart, like in alcoholic patient or any person with cardiomyopathy. Any type of cardiomyopathy, atria will be affected. So there could be ectopic foci created. So rate control will be the first step in these patients. After rate control, we will be talking about anticoagulation. And for anticoagulation part, I want to bring to your notice, I'll be just changing the color of my ink because this is an important aspect. If he talks about any patient having rheumatic etiology, you see, all of you are aware that rheumatic heart disease is related to mitral stenosis. And mitral stenosis will cause structural damage to left atria, because if mitral opening is narrow, the blood will not be able to travel forwards, no? So the atria will dilate. And once the atria will dilate, once you have a left atrial appendage dilation, then the bad news would be that the dilatation of this left atria is going to be the troublemaker. What I mean by the troublemaker here is that once you are having this left atrial dilation, structural damage, clots are developing, you have to go in for oral anticoagulation with warfarin. Yes, standard warfarin would be used. But if it is non-rheumatic atrial fibrillation, then we can use novel oral anticoagulants. So please remember the fact that if he specifically mentions rheumatic heart disease, then do not talk about the newer available anti-clotting agents. This point has been asked a couple of times even in the INISET exam, that especially with rheumatic etiology, what would you be using? So we have a tendency to answer the newer drugs. Yes, they're good, but they have not been tested in people with rheumatic etiology, because the incidence of stroke in these patients is so high that we cannot tell the son or daughter of this person that, okay, we're going to stop warfarin. The person is already on warfarin, no, to prevent stroke. I cannot tell son or daughter of somebody who is already on warfarin to prevent development of stroke that I'm going to test a new drug on your dad just to see how effective it is. And he'll say, sir, I mean, come on, what are you talking? You gonna test an untested drug on my dad? I mean, what if he develops stroke? Can you give me a guarantee that this drug will work? And I obviously can't give him a guarantee because these drugs have not been tested before in mitral stenosis patients with rheumatic etiology. So specifically for rheumatic etiology, answer it as warfarin. Otherwise, it is novel oral anticoagulants which are to be used. And now we come to alphabet C of this mnemonic, which would be to go in for chemical cardioversion. What I imply for chemical cardioversion here would be that I'll be using drugs to shut down the ectopic focus in the left atria. We first go in for chemical cardioversion. If that fails, then we can go in for electrical cardioversion. First is chemical cardioversion. If chemical cardioversion fails, then we can go in for electrical cardioversion. For chemical cardioversion, the drug that we shall be using is amiodarone. Amiodarone is actually used even in ventricular tachycardia also, no? So it would be called as a broad spectrum antiarrhythmic drug. But from the CMDT guidelines, if we also are going to talk about a newer drug that is used here, that is ibutilide. So depending on the availability, I mean, both or any one of these can be used. A lot of multiple choice questions, you would be having standard amiodarone only given, but if amiodarone is not given, then it would be ibutilide which must be considered. As far as the electrical cardioversion component is concerned, then electrical cardioversion component, you are gonna deploy it only if the chemical cardioversion will fail. That's important, guys. I mean, I want you to understand this fact that by race, I don't mean that I will serially do all these steps, in a sense that if chemical cardioversion is successful, then there is absolutely no issues. But in most of the cases, there's a possibility that the structural damage might be so much that the chemical cardioversion component might fail. And that would mean that I will have to go to the next step, which is going to be electrical cardioversion, where I'll be going in for DC shock. This would be 200 joules biphasic that would be deployed in the patient, and this would help in getting this patient get rid of this nasty arrhythmia, which can even contribute to sudden cardiac death. Race protocol, the way I've described, is to be deployed. I mean, we cannot bypass the steps. The query from a lot of people is that, sir, after all, it's a termination of a arrhythmia. So why don't you straight away go for electrical cardioversion? Because normally whenever we are talking about, let me say, VT or ventricular fibrillation, we say straight away go in for managing the patient with cardioversion or defibrillation, as the case may be. Here, why are you, beating around the bush, trying with drugs and then going in last for electrical cardioversion? Well, the difference is that this is a sustained arrhythmia. This could be present for a long duration. So because this arrhythmia is over a longer duration, the clot formation in the heart can occur. With VT or VFib, a person cannot be expected to survive beyond a couple of, person will become brain dead within next 4 minutes. If ventricular tachycardia occurs to me right now, or ventricular fibrillation, if it's a sustained VT or VFib, I would be brain dead in the next 4 minutes. I mean, all tachyarrhythmias develop so fast, there is no time for the clots to develop in the heart and then they're gonna move anywhere else. But when it comes to atrial fibrillation, because I use the word sustained tachyarrhythmia, there would be time available. This arrhythmia, in fact, this arrhythmia, thanks to the vagus nerve, could be having normal heart rate also. I mean, you saw here, no, that the heart rate of the patient touched normal. When I'm describing a tachyarrhythmia, the heart rate is supposed to be fast. In all tachyarrhythmias, heart rate will be more than 100. The only one where the vagus nerve can thankfully bring the heart rate of the patient back to within normal limits. Maybe this guy might be a marathon runner in the past. So thanks to his vagus nerve, the heart rate will touch normal. In no other tachyarrhythmia this is going to happen. So I've tried to give explanation for the fact that why is it so that especially with respect to atrial fibrillation, are we following so many steps and we are not straight away going in for electrical cardioversion in the patient. Because of the fact that decision of anticoagulation is important, and you may not be able to visualize the clots by transesophageal echocardiography or by transthoracic echo always. I mean, the clots may not be so big. So we have developed a scoring pattern. The scoring pattern is very simple. It's called as CHAD S2. In fact, the number 2, we give 2 marks for 2 components. One is for the age and another one is for the presentation of stroke. And from the exam perspective, all you are supposed to remember is the components of the score. I mean, nobody would ask you to calculate the total score. It is just the components of the score which are to be remembered. So let's look at CHAD S2 at the moment. I mean, let's do it in parts. CHAD S2 and then I'll talk about VASC. If a person is having congestive heart failure or hypertension, I mean, both of them are conditions which will cause structural damage to the heart. No, hypertension will cause LVH and then cause a left atrial hypertrophy. So CHF, hypertension, then A is age, D is diabetes mellitus, and then would be stroke. I mean, prior history of stroke that is already present. And now I want to draw your attention to the fact that the age component is coming twice in this particular scoring pattern. If the age of the patient is more than 75, we are giving, and you don't need to remember how many points are we putting in. That is just to make you more comfortable, that because age is coming twice in this classification. So if older is the age of the patient, we will be giving higher number of points. If the age of the patient is, I mean, relatively lesser, I'll say I'll give a relatively lesser number of points. And then the gender is also to be considered. And the point is, gender alone is not gonna be considered as a decision making point. Like suppose I say everything that I've written on the top, this is not valid for the case. Only thing is the patient is a female patient, then considering only the gender, I'll not say that okay, the score is 1 and we should be starting either aspirin or oral anticoagulation in the patient. So there should be at least a documented score of 1, but that should be beyond the component of gender. But the gender component alone will not decide the need for anticoagulation in these patients. If the score is 0, that's understandable. I mean, the maximum score possible here is 9. The minimum score possible here would be 0. And if the score is 0, then there is no need for any anticoagulation. If the score is 1, then either aspirin or anticoagulation would be used. But if the score of the patient is at least 2, then oral anticoagulation should be used. And when I say oral anticoagulation, which one would you use, the newer ones or the older ones? So this table from Harrison has been asked a lot of times, especially because they talk about rheumatic mitral valve disease as a comorbidity present in the patient with atrial fibrillation. He will talk about maybe the size of the atrial appendage as well. He might say that the left atrial diameter is more than 55 millimeter. Then it is warfarin which is to be answered primarily. But if it's gonna be a case where it's non-rheumatic condition, then the newer agents can also be used as well. The point is, I mean, wherever possible, in majority of questions, your primary answer should be given as warfarin, and the tendency to answer as newer oral anticoagulant agents should be one that should be avoided. As far as the components of CHAD as to VAC score are concerned, VA would stand for vascular disease. Vascular disease would mean peripheral arterial disease, because I divided this into two, no? Congestive heart failure, hypertension, age, diabetes mellitus, stroke. Then was VA is vascular disease, then age component coming up, and the gender component which is present. SC here means sex category. Alphabet S and a small c here means sex category of the patient. Now, once we have gone through the aspects of atrial fibrillation, I would now like to draw your attention to a patient of mine who's a big time smoker, and he came to me with complaints of palpitations and dizziness. And he says that the disease spells have been fairly persistent to the level that he might have even become unconscious and might end up with maybe a bruise on the head, or might even end up with a subdural hemorrhage as well. So considering that he was having these recurrent episodes of palpitations and disease spells, I decided to get the ECG of this patient. What caught my attention in the ECG was one, that there was a variation in the RR interval of the patient. I will at least be in the exam requesting you to count the RR interval twice. Now, when you look at the RR interval of this patient, you will notice that the RR interval of this patient is changing. I mean, it's going to 100, then going up to 150. So the first thought process of mine was that, okay, this could again be atrial fibrillation. But when I looked at the ECG, look at the vertical red arrows in this particular case, you will notice that P waves are present. There is presence of P waves. So am I gonna call it a presence of sinus arrhythmia? No, because sinus arrhythmia, the heart rate should not go more than 100. It's a physiological variation with respiration. The heart rate is not going to jump to 150. But in this case, you are having P waves. The only, I would say, problem here is, which will be the main point, is that the morphology or the size of the P waves, because the vertical height of the P wave, let me say with respect to the limb leads would be 2.5 millimeter. So in this particular case, the height of the P wave is varying, or the morphology of the P wave is changing. You see, the point is, in atrial fibrillation, P wave was not present. Here P wave is present. There is a morphology that is variable, and the heart rate of this patient is definitely going out to be more than 100 also intermittently. There is a variable RR interval once again. There are two things which I'm writing for the word variable. The first thing that I wrote variable was morphology of the P wave. That is one of the important diagnostic criteria. Second would be RR interval also, that is variable. So variable word is coming up twice, then the answer of yours would change over to multifocal atrial tachycardia. There are three situations that I have discussed where there's a variable or an interval. One would be physiological, that is sinus arrhythmia. But in this case, because the heart rate is jumping up much higher than normal, so I've decided, okay, this can't be sinus arrhythmia. And I noticed was a variable morphology. This variable morphology should be at least of three or more than three types. This again is an important pointer. The varied morphology, the P wave should be at least three different varieties of P waves should be present, or the size of the P wave and the duration of the P wave might be varying. So at least three subtypes or three variations should be present. Then we call it MAT, multifocal atrial tachycardia. If he says in the exam for management of multifocal atrial tachycardia, what would be the drug of choice that would be answered by you? Then your answer would be given as verapamil. And in this condition, we do not give DC shock. I mean, traditionally, whenever I'm going to describe any tachyarrhythmia, I'm always going to say DC shock. Either I will say cardioversion or I will say defibrillation. Differences between the two also you should know, and I'll write them down also. But at the moment, the message is that DC shock is not to be given. We will also make a list of when are you supposed to not give DC shock. This is one of them. I mean, he says you even if you give DC shock, the condition will reoccur. So it is primarily treating the cause, helping the patient quit the habit of cigarette smoking. And apart from that, obviously low flow oxygen will reduce the hypoxia to the heart. And once the hypoxia to the heart is reduced, then the chances of development of this tachyarrhythmia can be minimized. Next on the agenda is a strip, which would be very peculiar in a sense that you will be able to see these waves before every QRS complex, and you would be able to decipher that these waves do not look like the P waves. This would be called as a sawtooth pattern. And the moment I'm writing it, you would be coming out with the answer for this one. I'm very sure about it. This would be atrial flutter. Atrial flutter, I can say, is a variant of atrial fibrillation only. The only difference is the side of the heart that is involved is different. I mean, when it comes to atrial flutter, what we have here in this particular case is a re-entrant circuit. In atrial fibrillation, I said ectopic foci, which are present in the left atrium. But in atrial flutter, the problem lies with respect to the right side of the heart. It is a macro re-entrant circuit. It is re-entry phenomenon which is present here. So a bit of physiology concept coming up. It's a macro re-entrant circuit around the cavo-tricuspid isthmus which is responsible. What I write next, I mean, that's optional for you to just get a hang of the fact that with respect to atrial fibrillation, we don't read about re-entry phenomenon, but we read regarding multiple abnormal foci. We call it multiple ectopic foci. The location of them is the left atria, whereas cavo-tricuspid isthmus very well tells you it is right-sided. And why am I telling you this is that query from a lot of doctors is that, you know, when we read this physiology, we read about these terms like re-entry versus macro re-entrant circuit, re-entry phenomenon. So how are they able to pick it up, whether it's a re-entrant circuit, it is ectopic foci, because a routine surface ECG is not telling you anything related to that. So we have what is called as electrophysiological studies. You see, when you go to any cardiology unit, you will notice one room where it will be written EPS, electrophysiological studies, where to a non-medico, I will say, we will be doing mapping of your heart. That heart mapping that we do, you know, that topic focuses on the left, whether it is on the right, and how is it firing, what is the frequency of firing. We have special electrode, special study done that's called as electrophysiological study, where we can map out the tachyarrhythmia occurring in the patient. We can explain to a patient if he can understand, like, you know, from how is the current flowing in the heart, and how the re-entry phenomenon is occurring. I mean, he may or may not be able to fathom or understand all those terms, but the point is heart mapping. The word mapping itself would be sufficient for somebody to understand that the doctor is trying to, you know, check out the current flow in the heart, and if it is abnormal, then he would definitely require an ablation for it, or he might require a special intervention in the form of drugs. When it comes to atrial flutter, the sawtooth waves are relatively easy to pick up. So I will mention a important MCQ which will be discussed in neurology component also, because the question said sawtooth waves in EEG. You can very well see that there can be high error of judgment, because we read about sawtooth waves in the ECG, but here it is written sawtooth waves in the EEG of the patient, and then the entire perspective of the game will change, because this is a finding that we see with respect to REM sleep. So you need to understand the differences between the two, and then subsequently as we move along, the treatment of atrial flutter is also to be considered. Now, for the management of these patients, the first thing that we will do is rate control, and this rate control will be with respect to esmolol, following which we will be going ahead with anticoagulation. So the treatment of the patient of atrial flutter will be identical, but there will be a slight difference also that I'll mention before you. In chemical cardioversion, the same drugs will be mentioned, either ibutilide or amiodarone. But if ibutilide fails or if amiodarone fails, then what we can do in this case is give DC shock. But the intensity of DC shock that would be given here will be the least of all the values that I'll discuss with you for various tachyarrhythmias. Like when I talk about PSVT, I'll say DC shock of 120 joules going up to 200 joules would be required. But this is the lowest intensity of DC shock that I am describing at the moment. So this is itself a question that low intensity DC shock will be useful for termination of which tachyarrhythmia, and your answer would be the one on the slide at the moment, that would be atrial flutter. Both atrial flutter and atrial fibrillation, the treatment part is the same. It's just that the frequency of firing of this circuit versus the ectopic foci is different. I mean, atrial fibrillation, the ectopic foci might be firing at 300 to 600 times per minute, whereas the re-entrant circuit in this particular case would be firing usually in the range of about 150 to 250. And because the firing frequencies are different, that is why the ventricular rate in these patients can also be different. Now, once we have done these supraventricular tachycardias, let's focus on this ECG. And when we look at it the first time, we are thinking to ourselves, is it multifocal atrial tachycardia or is it atrial flutter? So one simple hack is that in multifocal atrial tachycardia, again, there was a variable RR interval. But in this case, even if you give a cursory glance, you will notice that the RR interval of the patient is not changing as it should be. And just for precaution, I have tried to look at the RR interval at least thrice. I'm not putting any numbers there, but I can say visually what I can pick up is RR interval is not changing, and then I'm able to pick up these characteristic waves. So this is once again atrial flutter, and the reason why this image was discussed is mainly to get you used to the fact that the morphology of atrial flutter would be different with respect to what I showed initially with MAT, multifocal atrial tachycardia. And multifocal atrial tachycardia again is something that initial people tend to love. It was continuously asked for, I would say, 3-4 years, and then the question became out of fashion. So I was a little, I would say, a little more descriptive for this one. Now, moving ahead, my next focus would be to talk about another supraventricular tachycardia. And let's look at this just like any routine ECG should be evaluated without even if the history is not given. Though he'll talk about palpitations, you should first start with lead number 2 right at the bottom. And my job would be initially to look at the heart rate. So when I look at the RR interval, it is, I have counted it at least twice to thrice. And every time you're noticing that the RR interval of the patient is pretty uniform, about 1.5 large squares. So the heart rate of this patient will work out to be 200 beats per minute. Once I know that there is a tachyarrhythmia occurring in the patient, my next job would be to look at the morphology of the RS complex or the QRS complex. And I can say the normal duration of QRS complex is about 80 to 100 milliseconds. So the QRS complex of yours and mine fits into about 2 to 2.5 small squares. You see, one large square is what I was talking about earlier, but every one large square would be having approximately 5 small squares. So if I focus on one small square at the moment, the duration of one small square in the ECG is about 40 milliseconds. And I would not suggest you to go into decimal system. 0.04, 0.08 is what people tend to remember. My suggestion to you is try to remember these values for like normal QRS duration in round figure. Like I said, 80 to 100 milliseconds, that would be about 2 to 2.5 large squares. Now, in this particular ECG, the QRS complex of the patient, the RS complex, in fact, I would say, because there's no visible Q here, is on the lower side of normal. And then if you cast a glance here, you will also notice that there is some magnitude of like, flattening of occurring here, which is some magnitude of ST depression also present. I'll just do the marking once again. This was the RS complex. and then subsequently there is a ST depression. And let me just zoom out of this ECG to show you that this ST depression is also present in other leads as well. Like if I move a little laterally to lead number V4, V5 or V5, V6, I'll use a single color to highlight this. This is R, this is S, and then there is a ST depression occurring. This ST depression is present globally, or why I'm saying global ST depression is because it is present in the lateral leads of the ECG also, it is present in lead number 2 also. So this is happening because the heart is beating too fast. Lots of time you read this word global ST depression. That global ST depression primarily means that there is evidence of subendocardial ischemia. Because there was a sudden acceleration of the heart rate, the demand of the heart is more and the supply is limited. Coronary arteries can provide a limited amount of oxygen. Suddenly there's an increase in consumption. So there would be a manifestation of hypoxia or ischemia in the heart. That would be a global ST depression. And in fact, the reciprocal change, you may be able to see some amount of ST elevation also present in AVR. AVR is going to be a reciprocal lead to the remaining leads. I mean, AVR always behaves, lead number AVR always behaves opposite of what the other leads are behaving, because in AVR normally the P wave, the first wave of the ECG, and T wave, the last wave of the ECG, is always negative. So you might be able to see ST elevation in lead number AVR, but in others, if you cast a glance and if I zoom out, you are able to see a global ST depression. Now the next wave that I'm showing here is neither a P wave. This is actually a wave that is formed by the merging of the T and the P waves. In fact, this is what I'm saying. Give me undivided attention and listen to the aspects here. The heart rate of this patient was previously normal. So I've just sketched a normal ECG. Now what is happening is the R and the R are coming close to each other. If R and the R wave will come close to each other, then the T wave, this is the T wave and this is the P wave of the subsequent complex. So I put a P and a P dash. Now what I'm saying is when R and R will come closer, this T and P will also come closer. The height of the T wave usually is less than 5 millimeter. The height of the P wave, T is 5 millimeter, P is 2.5 millimeter vertical height. T is 5 millimeter, P wave would be 2.5 millimeter. The two are coming closer to each other, so they get merged, and therefore this wave that is present here now would be called as a hidden P wave. So if I summarize all the findings that I have told you at the moment, the findings are as follows. There is a tachyarrhythmia occurring in the patient. The RR interval of the patient is constant. There is no variation of the RR interval, but there is a RS complex on the lower side of normal. There is a global ST depression happening and hidden P waves. This would be a ECG finding that is seen with the tachyarrhythmia by the name of PSVT, that is paroxysmal supraventricular tachycardia. In fact, sometimes it may even be written as AV nodal, because there's again a re-entry phenomenon occurring here around the AV node. So it may be written as AVNRT, that is AV nodal re-entrant tachycardia, and it is a narrow QRS complex tachycardia because the QRS complex in these patients will usually fit into two or less than two small squares. PSVT is a very common ECG that is asked in the exam, and in fact even in the recently conducted INICET May 2022 there was a question which began like this. He said diabetic patient presents with palpitations. So the first thought process is, okay, diabetic could be having a diabetic neuropathy, so he might be having even palpitations occurring, or these palpitations could be maybe because of a cardiac event. BP on admission is 122/80, and he says which of the following is a correct intervention. So before we go to the correct intervention, let me just zoom in to the ECG once again. We go down right to the bottom. This is lead number 2, and you will notice that there is a RS complex, then there's a slight ST depression, and then there's a wave which is formed by the merging of the P and the T. This ST depression, I'll just erase it so that you are able to analyze this relatively better. Let me use different colors for the different changes that I'm saying so that you can relate to this better. So I've used 3 different colors at the moment to sensitize you to the findings which are present here, and especially this ST depression that I have said here. I'm gonna show you this ST depression even present in the lateral leads also. So there's a global ST depression occurring in the patient. The ECG findings are those of PSVT, a paroxysmal supravent. I mean, identical ECG was given in the exam, luckily, and the guys were able to answer this very simple because for PSVT we shall be using adenosine. The only catch in the question was, I mean, why the answer is adenosine is because the BP of the patient at the moment was towards normal. If you get a question of paroxysmal supraventricular tachycardia and the BP of the patient is either unrecordable or for that matter of fact, the BP of the patient is less than 90 millimeters of mercury, then the answer will change over to cardioversion. Now, what is the difference between cardioversion and defibrillation? That is still pending, and that's my job to tell you. But the message at the moment is a lot of people actually they told me, sir, when I read this diabetic patient with palpitations, I looked at AVR. You're not supposed to look at AVR, but maybe, I mean, in the exam that they gave, this AVR was having very significant ST elevation. So people thought this is MIE. And for MIE, guys, I have told you a pattern, no? I've told you need to look at 2-3 AVF, or in V1 to V4 you will be having changes present. There was no pattern present, only AVR was having it. We can't say it as ST elevation MI by 1 lead and answer it as PCI. So people did make that mistake. It might look very silly to you at this moment that, sir, how can somebody make such a silly mistake? But then silly mistakes are what decrease down the score per se. So as far as amiodarone is concerned, it is useful for ventricular tachycardia, also in atrial fibrillation and in atrial flutter, but is not used in paroxysmal supraventricular tachycardia. So for PSVT, it's only two things to be remembered. At the moment, BP less than 90, it's cardioversion. If it is more than 90, it is adenosine. And as far as cardioversion versus defibrillation is concerned, I'm going to use two terms. One that is called as synchronized DC shock. When I say synchronized DC shock, it means that the computer will fire the impulse. The machine will fire the impulse with respect to the peak of the R wave. Like you can see here, the R wave is visible or can be understood by the computer. So the computer will pick up this R wave, BP of the patient is less than 90, and it will fire the DC shock to stop these fast contractions of the heart. The problem of the heart is fast contractions. If the heart will beat very, very fast, I explained to you, input will be lesser, output will be lesser. So if I want to terminate these fast contractions, the computer will pick up the peak of the R and will fire the impulse at the peak of the R. So we call it synchronized. And the computer does that automatically. But subsequently, I will be teaching you arrhythmias like ventricular fibrillation, in which there is going to be twitching around the baseline and there's no P, Q, R, S, T, U waves. I mean, nothing like normal is present. So the computer will get confused. The computer will not be able to understand the peak of the R wave because there is none. So this would be called as non-synchronized DC, and non-synchronized DC shock would be also referred as defibrillation. In fact, there are two terminologies that I've explained to you, and the terms to be noted down by you are that cardioversion and defibrillation are not to be used interchangeably. Cardioversion and defibrillation are terms which are not to be used interchangeably. Defibrillation is something which is called as non-synchronized DC shock, and the two arrhythmias where you will answer this is pulseless, not PSVT, but pulseless ventricular tachycardia and ventricular fibrillation. For all others, you will answer cardioversion. I repeat my statement. The only situation where you will answer non-synchronized DC shock or you will use the word defibrillation is for pulseless VT or ventricular fibrillation. Everywhere else you would be using the term cardioversion for synchronized DC shock, and in this case also it would be a synchronized DC shock that would be delivered. The intensity of the DC shock which is given in this condition would be ranging from 120 joules. If it not controlled by 120, you can increase the intensity. Like I was telling you, a range from 25 to 50 joules for atrial flutter. For paroxysmal supraventricular tachycardia, the range would be given as 120 to 200 joules. And this was actually a recent question. And I mean, they've just changed the blood pressure values. The description will remain almost more or less the same. It is just that the BP values keeps on changing in the question. I mean, sometimes it is like outrageously low value, 70 by 50. So, I mean, sometimes it's literally not possible to get such low values recorded. So, in those circumstances, the answer would be given as cardioversion. And thankfully, because this has been discussed multiple times, so I think this would be relatively easier for everybody to answer. Now, a word of caution for the subsequent ECG that I'm showing before you. What is happening here is that I can pick up a P wave. I mean, the standard thing is we first look at the heart rate. So the heart rate of this patient is about 45. And in this patient, as such, when it comes to the RR interval, there is not much significant change occurring, about 4, a little more than 4, I would say. Or I can say average for 75 is the heart rate of the patient. The moment the P wave is finishing, I'm not able to decipher a Q wave. That's not a cause of worry because in most of the leads, Q wave is not present. Q waves are mainly seen in V5, V6. Remember that small Q wave that's commonly seen in V5, V6. In most of the other leads, you may not be able to identify the Q waves. Now, what is happening is a very peculiar thing happening, which is that when the R wave is going up, the R wave is not going up straight. The R wave is not going up straight. There is a change in the slope of the upswing of the R wave. This change in the slope of the upswing of the R wave is of concern in this condition and is what is called as delta wave. So another abnormality that is being taught to you at the moment is with respect to not the morphology of the P wave, but now we are moving a little further ahead towards the QRS complex. This QRS complex, I would say the R wave upslope is having a slurring, or I can say there's a change in the slope in the upswing. So we're gonna call it a delta wave. Delta wave is a ECG finding of a condition where there is an accessory pathway in the heart. This patient's heart is having two conduction pathways. One is the traditional one, I mean SA node, AV node, bundle of waves, and Purkinje. He's having normal also, but he's having a abnormal conduction pathway in the heart also, which is called as bundle of Kent. I will be making a line diagram of the bundle of Kent subsequently, but at the moment the main focus is delta wave is a ECG finding of Wolff-Parkinson-White syndrome, and see how he can play a trick up here, that the question will say delta wave, our thought process would be Wolff-Parkinson-White, and he will say delta wave in EEG. Just like I had drawn your attention to the fact that sawtooth waves in EEG, the answer would change over to REM sleep, obviously because we are talking about EEG. Similarly, when you read about delta waves in EEG, this would be one of the slowest waves in EEG that are noticed in the deepest part of the sleep. One of the deep parts of the sleep that we go into is called as slow wave sleep and is called as NREM stage 3. So do look out for the fact that, in our rush to answer those one-liner questions, is he asking about ECG and EEG? It looks very silly when I point them out, but I do find people making mistakes, so it's my job to sensitize you to the same. Delta wave in WPW will be a cause of big problem in the heart of this patient, because this is like a short circuit. So before we focus on the treatment part, let's have a look at the line diagram so that you can understand this better. You see the black here is representing the normal conduction in the heart. In you and me, the current will go from SA node, then will go across the AV node. And why I've shown this conduction of the AV node in dotted fashion is because there is a AV nodal delay. The current around the AV node in your and my heart travels relatively slowly. There is vagus nerve that is present here. The AV node is also called as the gatekeeper of the heart. So the point is that if you focus on an area around the AV node, you can consider this to be a broken Indian road. On the other hand, the red pathway that I've shown, the red circuit that I've shown, which is bypassing the entire circuit, it is directly causing the impulses to travel from the SA node. All the impulses of the SA node can travel via this abnormal pathway called as bundle of Kent and can directly make the ventricle contract, is the speciality of this condition. And this pathway, the one that are shown in red, has very fast conduction. It does not have a decremental property. Our heart AV node has a decremental property, so I use the word AV nodal delay. But this is like an express highway, so the current will prefer to go through the pathway of least resistance, and because of the fast conduction that occurs in the heart of these patients across the bundle of Kent, therefore I can say that these patients of WPW who are having a fast conduction in their heart, these patients are destined to suffer from palpitations. Most of the time the complaints of these patients would be, the doctor, right from a very young age I have palpitations and even recurrent syncopal attacks. Important part of the history that I'll be also encountering in this particular case would be that he said that my elder brother was dancing at a marriage party just like him, and he unfortunately expired. And that would be like a very shocking statement that this person made. Maybe initially I might be taking this person a little casually, but the moment I read about this sudden death in sibling, or rather the word sudden cardiac death in sibling, then I definitely need to give importance to this particular statement, and I'll be doing ECG of this patient. Now, when you do the ECG of this patient, you will be getting a very specific finding, which I would like to explain before you. And this involves a bit of mathematics. So I would like you at this moment not to note down the information, but rather follow my words initially. You see, you are aware that the PR interval is from the starting of the P wave to the starting of the Q. I mean, name is PR interval, but it is not till the R wave, it is the starting of the Q wave. And then the second dot that I put here, in fact, I'll just use a different color to highlight it. The end of the S, I put a yellow dot here. This would be the QRS complex. This is the QRS complex, understandable. But the end of the S is also called as J point. So the message for you guys at the moment is that if I combine these two, if I combine the PR interval with the QRS, then what I generate here is what is called as the PJ interval. The technical term is PJ interval is a sum of two things, that is PR plus QRS. Now let's focus on the mathematics in this case. When it comes to patients who are suffering from Wolff-Parkinson-White syndrome, because there is a fast conduction occurring in the heart, therefore PR interval of the patient will be short. A basic rule of ECG is that PR is always inversely related to heart rate. If this person sitting on a chair will be having a heart rate of, let me say, 110, 120, heart rate is more, so PR interval will be relatively lesser. Let's now focus on the QRS complex. The reason why you get a QRS complex from physiology perspective, the reason for QRS is septal activation. The black arrow that I put here before you, which is going from left to right, is responsible for the generation of the Q wave in ECG of a normal person. But in WPW, this Q wave will not be generated. Why? Because the current is not going by the normal pathway. The current is not going into the bundle of phase. This is the area of the bundle of phase. The activation should occur of this bundle of phase, and that is when you should be having a Q wave. But in this patient, the current is short circuiting directly into the ventricles. So we are not going to be having the Q wave in the ECG of these patients. Q wave is absent. Now we'll focus on the RS complex. When I focus on the RS complex, I want to say that because the current is entering the wrong way in the heart of this patient, the way the R wave develops in this patient will not be normal. In fact, the ECG would be something like this. The moment the P finishes, the PR interval is going to be short, and then there is a change in the slope of the upswing of the R wave, as I have shown at the moment. This change in the slope I have slightly exaggerated it also, and this is the delta wave, and this actually contributes to the RS complex of these patients being slightly broader. In fact, there are two reasons why I can say the RS complex in these patients is broad. One is that the current is not going via the Purkinje fiber. Purkinje, as you know from physiology, is the fastest conducting fiber in the heart. But now in this patient, how will the current go? The current will go from directly from myocyte to myocyte. In you and me, current goes by the Purkinje fiber. Purkinje fibers are modified muscle fiber. Imagine the height of evolution. I am saying there is a muscle fiber in the heart that behaves like a nerve fiber. Purkinje fiber it was itself a question. It's a modified muscle fiber, but in this particular case, this Purkinje fiber will not be utilized. Purkinje fiber has been shown in black. Rather, these patients will be having intermyocyte conduction, and intermyocyte conduction is slower. The words are intermyocyte conduction is slower than the Purkinje fiber, and because I'm using the word slower, so the RS complex will become broad. Now we focus on the mathematics here. What we have seen in this condition is that the amount by which the PR will become less, the amount by which the PR will become less, RS will become broad. The amount by which the PR will become less, the RS will become broad. So therefore the PJ interval of this patient will remain unaffected. That would be normal. I repeat my statement. The amount of PR reduction is equal to the prolongation of the RS complex. The amount of PR reduction is equal to the increase of the RS complex. So therefore the PJ interval in these patients remains normal. So there are three important diagnostic ECG features which are present here. Point number one would be PR would be short. The Q wave of this patient is relatively absent. That's because of the absence of the septal activation, and the RS complex is broader, due to which PJ interval is normal. And I'll just jot these findings on this particular slide as well. Now, why am I repeating it? You will get an idea about it, or you will get a better understanding of it if you continue listening at the moment. I said there is a short PR, there is a delta wave present. That was the change in the slope of the upswing of the R, and PJ interval in this condition happens to be normal. Now, why did I write it? Follow the line diagram here. The current in the heart of a normal person like you and me goes from SA node to AV node, then goes across the two sides of the AV node and causes septal activation. The current then first goes to the left fascicle, then to the right fascicle. Then we have is the Purkinje network, which is the fastest conducting fibers in the heart, and this is the cardiac muscle. In the patient that I'm showing at the moment, there is a short circuit, and this short circuit is different from that of Wolff-Parkinson-White syndrome. If you look at the line diagram of WPW, you will notice the fact that I had shown the short circuit going like this. The current was going with help of this short circuit directly into the ventricular myocardium, but currently the accessory pathway that are drawn before you is going directly into the bundle of his. The only thing that is happening in this case is that there is a bypass of the AV node, because I told you AV node is very slowly conducting. I told you we have is a AB nodal delay. The conduction across the AV node is slow, so the current will prefer to bypass this entire AV node and will directly hit the bundle of phase and cause a septal activation. So that I have not even named the condition at the moment, but you can understand at the moment that there would be a Q wave present in the ECG of this patient, and then this current will travel just like the current in the heart of yours and mine. It will utilize the Purkinje network. It will utilize the Purkinje network and will cause the QRS complex. This condition that I'm describing now before you is called as Lown-Ganong-Levine syndrome. This particular condition that I've written here before you is also having an accessory pathway in the heart. There are two conditions that I've told you today that are having an accessory pathway in the heart. One is Wolff-Parkinson-White, and the second one is Lown-Ganong-Levine. Obviously the fiber which is present here, or the conduction fiber which is present here, is different. Like I was teaching you in WPW, the word was bundle of Kent. At this point of time, he might actually use the word James bundle. Now, once you get these names right, James bundle versus bundle of Kent, as I mentioned initially, the highlight of this condition is even in this condition, the PR interval will be short because the current is traveling faster through this James bundle that I've drawn. But you will be getting a Q wave in this patient, and the QRS complex of this patient will be normal. Normal, why? Because the conduction is occurring not intermyocyte, but Purkinje network is being utilized in this case. Remember last time I told you that intermyocyte conduction is slower, so RS complex was broader. Now comes the mathematics. I'm going to write that formula once again. PJ is the combination of PR plus QRS. What is happening is PR is short and the QRS of the patient is normal. So if you look at the mathematics here, the PJ interval of the patient will be short. And if you're paying attention to me carefully here, you will notice that few milliseconds earlier, or rather few seconds earlier, I had told you PJ is normal in WPW. Sir, this technical detail might look very minor to you, but believe me, this was asked in FMG exam. And I mean, I did talk about an INISTAT MCQ earlier. I mean, in FMG exam, the question was, what is the differentiating ECG criteria between WPW and Lown-Ganong-Levine syndrome? And the students of mine said, sir, we were looking for delta wave in the MCQ. Delta wave was not given in the choices. You know, if he gives delta wave, it's a piece of cake. I mean, you can straight away answer delta wave is one of the important diagnostic features for WPW and differentiates it from a case of Lown-Ganong-Levine syndrome, but there was no delta wave given. Then your answer would be what I've just explained to you. PJ interval is normal in WPW, but is always reduced in Lown-Ganong-Levine syndrome. And once you get this information right, now we'll be talking about the treatment of this condition. The treatment of both of these conditions, I'll just write treatment part here. The treatment for WPW and Lown-Ganong-Levine syndrome is same. I mean, what is the ideal treatment? The ideal treatment is get rid of this abnormal conduction pathway. his heart is having two pathways. One is the normal one is the abnormal one. So what we can go in this, we can go ahead in this patient is with a radio frequency ablation, which is the treatment of choice for this condition. But now another problem can arise. The another problem that can arise is that he might say that the person may not be able to afford this, so we will have to give drug treatment for this patient. Now, if he talks about drug treatment in this patient in an emergency scenario, like this person came at the moment with palpitations and he's also feeling dizzy, then in emergency scenario, we are using procainamide for these patients. But at the same time, if he says what drug will be used to prevent such episodes in future, then we have to give a drug that will act on either the bundle of Kent or on the James bundle and slow the conduction. If you slow the conduction in the heart through the James bundle, or you slow the conduction through the bundle of Kent, then the current will be forced to go via the normal pathway. So the oral medicine that we can use in these patients for preventive purposes happens to be flecainide. These aspects are to be remembered by you, especially because if he talks about prevention part, then you need to not answer as procainamide. That's used in the emergency scenario for these patients. Now, I would like to go back in one of my slides, because since I've talked about the prevention component here, so just prior to this, the topic that I had explained to you was paroxysmal supraventricular tachycardia. So if he says in the exam that, remember I talked about PSVT and I told you that we are gonna go ahead with either adenosine depending on the blood pressure value or cardioversion if the BP is unrecordable, he might say that how would you prevent a episode of paroxysmal supraventricular tachycardia from occurring in the patient? He would like to ask what the drug component in this case. So your answer in that case would be given as verapamil. Verapamil I spoke about as the drug of choice for multifocal atrial tachycardia. I also taught you that this could be used for rate control in atrial fibrillation and atrial flutter. So actually this is gonna be the fourth time that I'm talking about verapamil at the moment. Earlier I've talked about verapamil for I repeat once again, rate control in atrial fibrillation, atrial flutter, and I also talk about it for in case a person is having multifocal atrial tachycardia. So here it is rather prevention of the re-entry phenomenon occurring in the heart of this patient. In fact, I'll just invest one more slide here, and this will make the treatment of paroxysmal supraventricular tachycardia clear to you, because they give different scenarios. The scenarios that can be given can be like this. One, he can simply mention crushing patient. The second possibility is that there would be no discussion of crashing patient, but rather the person is hemodynamically unstable. The systolic blood pressure of the patient is more than 90 millimeters of mercury, and then is prevention part. Now, if he describes a crashing patient, then it is always a synchronized DC shock. I've already explained to you that synchronized DC shock, the impulse will be fired with respect to the peak of the R wave. So I am gonna also write the word cardioversion. Both of these words are interchangeable, but this is not interchangeable with defibrillation. If the patient is hemodynamically stable, I need to give adenosine, but it will take some time for your staff nurse to procure adenosine and give it to the patient. Adenosine also has a side effect. It's transient, but still it can freak out a patient. So you must warn the patient that when you give this injection, he might feel a bit suffocated. There's a transient bronchospasm that you see always with adenosine, and this must be forewarned to the patient. But before your nurse will get opportunity to actually load adenosine and with your permission give it to the patient, if he says what is the first line management for a hemodynamically stable patient, your answer would be given as carotid sinus massage. For carotid sinus massage, which is a recommended procedure in pediatric MCQs, you will notice that he may not mention, or even if carotid sinus massage is given, I would recommend you not to answer it in pediatric age group, because one, the neck in the children is shorter. Because the neck is shorter, the surface marking will be difficult. I mean, you may not be able to press at the right spot. Second, child may not be so cooperative. If he is having palpitations, even if his BP is, even if he is conscious, he may not be cooperative. So in those circumstances, especially in child, if he gives you a scenario of a hemodynamically stable child with PSVT, it is face ice pack. Both are vagal maneuvers which will help you control the re-entry phenomenon. And in case adenosine fails, if we are having a chemical cardioversion, which fails in this case, then we anyway have a DC shock, which I've already told you would be synchronized DC shock. The intensity of this will range between 120 to 200 joules biphasic. For the prevention part, it is either going in for a procedure of ablation. I mean, the re-entry pathway can be controlled by procedures where ablation can be done. But because they love to ask about the drug component, therefore verapamil would be used in these patients to prevent such attacks from occurring. So we do have interventions by which we can handle the re-entry phenomenon, but mainly because they love to ask about the drug component. So I thought I'll just mention about this slide. And we have today learned that flecainide is to be answered for prevention of episodes in accessory pathway condition. This is common treatment for both WPW and Leuengang-Levine syndrome, and don't rely only on the delta waves in the exam to differentiate between WPW and LGL. The PJ interval should be given its due respect as he demands in the exam. This is a repeat. Delta wave on EEG and sawtooth waves on EEG are seen in NREM3 and REM stage. And as far as today is concerned, I have taught you conditions which could be having a narrow QRS complex tachycardia, that is supraventricular tachycardias. Supraventricular tachycardias that I've described are like PSVT, which you have a hidden P wave, atrial fibrillation where there's an absent P wave or atrial flutter. Then wide QRS complex tachycardia is what we'll discuss subsequently in the forthcoming slides. This would be ventricular tachycardia, or it could be polymorphic ventricular tachycardia, which is also called as Torsades de Pointes. So on the subsequent slides, I'll be explaining those broad complex tachycardia before you. Then is a new term, Osborne wave. I'll also show you how Osborne wave looks like, but let's fill in the data. Where do you get it? You would be getting it when the core temperature of the patient would be less than 35 degrees. The preferred site for checking the core temperature, the ideal site for checking the core temperature is pulmonary artery, but that would be, I would say, an invasive method, a very invasive method. So on a comparison basis, there are two MCQs. One says what is the ideal site for checking the core temperature? Answer is pulmonary artery. But if he says preferred site, then don't answer rectum, because the thermometer might be touching the feces and not the rectal wall, and you would be, and the feces might be frozen in, let me say, a soldier who was buried under ice for a few hours. So the message is that don't answer a rectal thermometer, answer it as lower esophagus, which is the preferred site for checking out the core temperature. And a special ECG finding that I'll hand draw before you would be Osborne wave. Then with respect to the QRS complexes, there's also possibility that you might come across a R wave, which in the top might be having a bit of slurring. I can either call it this appearance that are drawn before you, I can call it a rabbit ear appearance. No, looks like ears on the rabbit. Or I can just use the word M, or I can use the word W just to describe this notching which is present. And this is what we always see in patients who are having bundle branch block. Now, whether it's going to be right bundle branch block or left bundle branch block will vary, but the message is in bundle branch block, this M pattern, which can be also referred as rabbit ear appearance. In fact, I'll just write it also. This rabbit ear appearance represents again intramyocyte conduction, is found in patients having bundle branch block. For left bundle branch block, because I'm using the word left, this pattern could be encountered in V5, V6. Whereas the same pattern could be present in V1, V2 for right bundle branch block. But these are some theory-based MCQs that you should be comfortable with. And I would now be showing before you a question which mentioned regarding a soldier who was, let me say, posted at Siachen Glacier, and there was an avalanche and he was buried under ice or snow for a long duration. In any patient who would be having hypothermia, there would be slowing of the heart. So the PR interval of the patient might be prolonged. In fact, in some cases, P wave may not be even decipherable. The SA node, in hypothermia may not be firing like normal. And then a special finding would come up, which is already highlighted, but I'll just do the marking for this once again. This is R going up, this is S coming down. And when it is coming down, then you can notice I would say a notch present. You see, when I was describing delta wave, it was in the upswing of the R. Delta wave was in the upswing of the R, but this that are drawn before you is in the downswing of the S. I mean, a downswing of the R wave. So what I can say is this is what is called as Osborne wave. I'll try to hand draw this before you once again. There is a possibility that in these patients there might be either inverted P waves present. That could be because the AV node might become the boss of the heart and it is firing the atria retrogradely. So maybe an inverted P wave. And then this is R. When it is coming down, then you are getting what is called as a Osborn wave. Therefore, this is a finding that is encountered in patients of hypothermia. As far as hypothermia definition is concerned, the core temperature of the body, if it is between 30 to 35, we call it mild hypothermia. If it is between 28 to 32, we call it moderate hypothermia. And if the value is less than 28 degrees Celsius, we would be calling it severe hypothermia. The preferred site for checking the core temperature has been mentioned as the lower part of the esophagus. The reason I'm repeating again, the feces might be frozen and you might be getting an erroneous recording from the feces and not from the rectal wall. Then another finding that I've highlighted is the slurring that I was saying, or the rabbit ear appearance that was coming up. If this is going to be present in lead number V5, V6, there are multiple other findings also, but if you notice the stuttering present, especially in V5, V6, then this would be a feature suggestive of bundle branch block. In fact, the opposite of this can be noticed in V1, V2, and I'm just going to hand draw this before you, that you'll notice that this rabbit ear appearance might be present in the S wave. It might be a RS complex which is relatively broader. The way I've drawn it, the RS complex is relatively broader, and the rabbit ear appearance, let me just make it more characteristic. The rabbit ear appearance might be noticed in a deep broad S wave. So if these two findings are given together, like he says, V1, V2 in the S wave, that's the rabbit ear appearance, and in V5, V6, the rabbit ear appearance is present, then this is left bundle branch block. And the findings that I've told you at this particular point of time are as follows. For the QRS complex per se, the finding for the QRS complex can be narrow, it can be broad. Then in the downswing of the R, you could be having an abnormality, you could be having a problem in the peak of the R wave as I've shown, or in the depth of the S wave as I've shown for bundle branch block. There are other diagnostic criteria also that you can go through in the main section of the app if you are interested about studying differences between left and right bundle branch block. Now, just to take the pressure off, because when you start learning all these facts with respect to QRS complex, it puts a lot of pressure on the mind, and therefore we tend to get a little tired. So what I thought was I'll discuss three MCQs here before you, and then subsequently we'll focus on the wide complex QRS tachycardia. The question was a very easy one. The question said, which of the following is not an adaptation at high altitude? So if a person goes to Leh or Ladakh or maybe to Khardungla, the highest motorable route in the world, the person will be having pulmonary vasoconstriction, hypoxia. The higher you go up, the oxygen will be, concentration will be lesser, air will be thinner, so oxygen concentration will drop. It causes pulmonary vasoconstriction and it causes a cerebral vasodilation. Now, why the difference is because hypoxia causes dilation of all blood vessels in the body. Listen to my words carefully. Hypoxia causes dilation of all blood vessels in the body except pulmonary artery. Why that is so is because pulmonary artery is actually not an artery carrying oxygen. No, it is an artery carrying carbon dioxide. So it behaves a little opposite. I said hypoxia causes cerebral blood vasodilation, and this cerebral vasodilation will cause stretching of the dura mater and the trigeminal nerve endings, and that can actually contribute to headache in the patient. So if you have really gone to, I mean, really real high altitude, I'm not talking about Shimla, Mussoorie kind of thing. I'm talking about, let me say 16,000 feet or even 12,000 to 16,000, which is very difficult for people who are living in plains. All our life we have lived in plains. So when you go to those high altitude area, headache really hits you, and that's because of cerebral vasodilation. Similarly, there would be a pulmonary vasoconstriction. So both of these things are okay. And then because of hypoxia, there can be tachycardia. But what happens is that the person will be breathing faster. Because the person will breathe faster, it will be causing carbon dioxide washout from the body. and this carbon dioxide washout will then result in development of respiratory alkalosis. Whenever carbon dioxide in the body becomes more, it is respiratory acidosis, but if there is a carbon dioxide washout, it is respiratory alkalosis. The answer to this question would be option number C. And since we were talking about hypothermia related to soldier posted at high altitude, I thought I'll just discuss this INISET MCQ with you. Now let's move on to the next one. This one said, which of the following is not associated with central cyanosis? So if you look at the first option, that is methemoglobinemia. Methemoglobinemia will basically be oxidized hemoglobin, that Fe2 plus is converted into Fe3 plus. So it will not be able to carry sufficient amount of oxygen, and the type of hypoxia in the patient is anemic hypoxia. So the lips will turn blue and fingertips will also turn blue. So central cyanosis will be present. But hypothermia, which we were discussing as core temperature less than 35, will be causing localized vasoconstriction, and because only the finger and the toes of the patient will turn blue, or maybe earlobes or fingertip of the nose might be having a bluish tinge, so I'm going to call it peripheral cyanosis. Question is, which of the following is not associated with central cyanosis? Then hypothermia will be associated with peripheral cyanosis. Was an easy one. I mean, a lot of people were able to answer it even without reading the other options, but that's actually not a good idea. So let's look at option number C, high altitude. When you go to high altitude, then what's going to happen is that there would be a development of hypoxic hypoxia, because the concentration of oxygen in the atmosphere is lesser. In point number A, I was saying it is delivery that is lesser. In point number C, I'm saying that the total concentration of oxygen available is lesser. And when I look at pulmonary AV malformations, then this will be an extra cardiac shunt. Normally we read about like right to left shunt in the heart, no? We read about mixing of blood. Here also there is a mixing of the blood occurring, but it is not occurring in the heart, it is outside, because arterial blood and venous blood are mixing. So that will again explain the central cyanosis in the patient. So option number A, because of anemic hypoxia, option number C due to hypoxic hypoxia, option number D due to extra cardiac mixing would be explaining the central cyanosis component, but hypothermia would be a cause of peripheral cyanosis. Another question that I'm discussing before you said calculate the axis of the patient. I mean, he gave a graph like this, and then he said calculate the axis. So before we come to, I mean, why is it left ventricular or right ventricular enlargement, let's just focus on the baseline information that you should be aware of with respect to calculation of the axis. In a normal individual, you can draw a curve like this. On the x-axis would be lead 1. On the y-axis would be lead number AVF. Then put marks like plus and minus here. Like on x-axis on the right hand side is plus, on the left side would be negative mark. But when you're doing this plus minus marking for AVF, pay attention to the fact that plus marking would be on the inferior part and the minus marking would be superiorly. Normally, if you go by mathematics, on the y-axis, like this particular area on the y-axis is where you put plus sign in mathematics, and minus sign inferiorly, but here you're doing ulta, you're doing opposite. So this is to be remembered initially. Now, as far as the normal axis of the heart is concerned, the normal axis of the heart of yours and mine is in the range of minus 30 to 90 degrees. Though some books might say 110 also. There could be slight variation between different books, but minus 30 to 90 is the normal axis of the heart as far as you and me are concerned. Now, what I will do is a bit of mathematics, so please be patient and hear me out here. To calculate the axis, what you're supposed to do is just look at the number of the boxes in the R wave as compared to the S wave, and you can see that the R wave is much bigger as compared to the S wave. So what I'm doing is I'm subtracting the depth of the S, whatever is the, I mean, it's only one small box. For R there are multiple small boxes, but the message of mine is that R minus S vector will be positive. Why is it positive? Is because R is much bigger than S, so electrical vector per se will be positive. Now you will focus on lead number AVF. In lead number AVF you will notice R is very small but S is relatively deeper. So if I look at the mathematics here, I've deliberately written R alphabet small because height of the R wave is very small, and the mathematical output of this would be that R minus S, if I subtract, this will be negative, because why? The depth of the S wave, there are so many small squares. In fact, it's going into 2.5 large squares. and r is hardly one small square. So the final output is r minus s is negative for AVF, and for lead number 1 is positive. Now let's just plot this, and this plotting would be done like we do in class 10th in vector analysis. I said on lead number 1 the vector is positive, so okay, this is positive vector, let me say, and on lead number AVF the vector is negative. So I am just gonna join them together like we do in class 10th, and you will notice that the cardiac axis is not following in the quadrant that it was supposed to be. That was supposed to be between the two blue lines, rather it is moving up superiorly. So if the vector points in this area which I've shown in color green, we are gonna call it a left axis deviation. And left axis deviation, why do you want to calculate it, is because this is usually seen if there is a left ventricular hypertrophy. Like suppose somebody is having hypertension person will develop left ventricular hypertrophy. Now how do you diagnose left ventricular hypertrophy? Either you do echo or you have ECG criteria. But one fact that I simply said was that all conditions that contribute to left ventricular hypertrophy will always be having left axis deviation. So axis deviation actually lets you know indirectly which chamber of the heart is relatively bigger. Let's do this activity once again and you will feel much more comfortable about it. So suppose I am given a ECG like this in the exam and they ask me to calculate the axis. I may not have a paper pen. In a real exam, there is no paper pen available. So you have to do it in your mind. Just get the plus and the minus signs right. With respect to mathematics, on the y-axis, plus should be on the top, but you can see I've shown the plus at the bottom. Now I will mention that normal axis of the heart is minus 30 to 90 degrees. This is where the axis should fall. Let's look first for lead number 1. In lead number 1, you hardly can see a R. It is only a S wave that can be seen, hardly a R. So I can say that the final vector will be negative because S is a negative wave. It's a predominantly negative vector in lead number 1. So I'm just going to plot it. This is negative vector. On one side it was positive, it was negative with respect to lead number 1. Now let's look at lead number AVF. It's predominantly positive. I mean, there is only a R, there is hardly any S. So I'm going to write R minus S is positive. And if I just plot this data and join it here, then the axis is actually following in. This is mathematics, guys, and the axis is falling different from where it normally should be. I mean, this is normal axis, but you are noticing that the axis is falling rather to the left side of the normal axis. This is a right axis deviation. So today I've taught you that if you calculate axis that falls in this particular quadrant, you want to call it left axis deviation. Suppose you get a ECG in which the axis is falling in this particular direction, that is lead 1 is also negative and lead AVF is also negative, then we are going to call it a extreme axis deviation. So I've taught you regarding axis deviation and what does it signify. If it is right axis deviation, it signifies right-sided enlargement of the heart. If it is left axis deviation, indicates left-sided enlargement of the heart. Extreme axis deviation, well, this could be seen in a tachyarrhythmia like ventricular tachycardia or VT. But on the basis of this information, let us just go to this question that came in the exam. What happened in the exam was that they had drawn a curve like this. This is like lead 1 AVF. Normal axis of the heart was not mentioned. He just mentioned that the final vector, the final vector is pointing like this. Because the final vector is pointing like this, which is different from where it should be. Let's mark out the normal areas here. This is where the normal axis of the heart should be. This is going to be the vector of right axis deviation, and actually he did not ask about per se axis deviation. He said which chamber of the heart. The options were that this schemata shows enlargement of which ventricle. So right axis deviation would be related to the right ventricular enlargement of the patient. Suppose in the exam the vector was going like this. The vector was pointing in this particular quadrant, then you would have answered left ventricular hypertrophy of the patient. So the objective of knowing this information is only relevant with respect to chamber enlargement, though nowadays we have echocardiography, which is an easier way for chamber enlargement. But because they would like to know about this axis, I would request you to just hand draw this by yourself. This is simple mathematics, and why this is important is because in the exam they don't give you a paper pen, so you would have to do this mentally. R, like if we do this again, no, the look of this is R is taller, so you have to plot it on the right hand side of the x-axis, and the AVF you have to plot it to the negative side, that is superiorly. And if you just draw the green vector here, positive for 1 and negative for AVF, you are able to identify the left axis deviation. If this is looking overbearing to you, I understand that this is mathematics. We doctors are not good with graphs and papers like these. So I mean, a lot of people, they get a little I would say disinterested at this point of time. But what I have done at the moment is just try to take your mind off only tachyarrhythmias and focus on two MCQs of the recently conducted INISET exam and one question. This question of axis was actually in the FMG exam. So two INISET and one FMG exam question have been catered, and now we come to another tachyarrhythmia where you will notice that the distance between the R and R is again substantially reduced. The heart rate of this patient would be approximately 200 beats per minute, 1.5 large squares. So 300 divided by 1.5, the heart is doing just too fast, 200 beats per minute. Now let's look at the waves which are present here. So the waves are very characteristic in a sense that this anything that goes up, no, anything that goes up would be called as a R wave. And then you are also noticing a slight slurring, and then this is the S wave of the patient, right? So what is present in this case, in fact, the vector that is going up, the one that I've shown in color blue would be the R wave, and then is the S wave of the patient, and the QRS complex of this patient is really, really broad. I mean, I said this is R, you can yourself see R is broad, and then S is also broad. So overall, if you look at the QRS complex of this patient, the QRS complex of this patient is broad in a sense that normally the QRS complex should fit into 2 to 2.5 small squares. Normal QRS is what I have described is 80 to 100 milliseconds. That would be 2 to 2.5 large squares. But if you encounter tachycardia and the QRS complex of the patient is broad, your diagnosis would be given as VT, that is ventricular tachycardia. As far as VT is concerned, this is one of the easier ECGs that people are able to identify. A special finding of ventricular tachycardia, which is also shown in this image, is what I would also like to highlight. This slight notching which is present. This notching that is present is called as Josephson sign. I'll just jot it here only. This is referred to as Josephson, that is in the downswing of the R. Not very important, but yeah, I mean, just once you get a visual representation of this, it would be, or a mental orientation of this is R, then the Josephson sign coming up, and then would be a broad S complex present. So this is a broad complex or premature ventricular contractions occurring again and again. I said PVCs, premature. Normally we first have atrial contraction, then we have ventricular contraction, and the two should be coordinating. But in this case, the coordination component is not there. So the ECG of this patient is revealing presence of VT, ventricular tachycardia. And now we focus on what are we gonna do for the management of this patient, and the answer will depend again on the blood pressure values. If he says patient is hemodynamically stable, then the drug that you can be using in the patient is amiodarone. But if he says unstable patient, then we have to give DC shock to this patient. The intensity of this DC shock would be 200 joules. And if he says what is the next step after giving a DC shock in the patient, then the next step after giving DC shock would be that the whole team would start looking towards the monitor, because you delivered a DC shock. So you think that the normal sinus rhythm should be established, but that would take some while. And before the rhythm resets to normal, you must continue the CPR in the patient. I mean, the question in the exam was DC shock has already been given to a patient of ventricular tachycardia. He himself told ventricular ECG was given, but he said this is the case of VT. Doctor has already given DC shock. What is the next step for the management of the patient? The answer is continue the CPR, because it will take some time for the rhythm to reset to normal. And if you continue the CPR, then the chest compressions will ensure good blood supply to the brain. And I would like to minimize the damage to the neurons. In any hemodynamically Stable patient, it is amidron, and if it is unstable, then DC shock should be given. And as far as the protocol is concerned, we should always be remembering that DC shock would be given max of 3 times. So I'm just jumping one slide to actually show you that I have discussed even in basic life support, that whenever you read about shockable rhythm is ventricular fibrillation and pulseless ventricular tachycardia, whereas the right side would be called as non-shockable, because DC shock is not given in asystole, and neither do you give DC shock in pulseless electrical activity. Causes of pulseless electrical activity could be like cardiac tamponade. There is lot of fluid outside the heart crushing the heart from outside. Or pulseless electrical activity could be due to tension pneumothorax, where you will have to put a wide bore needle, and this air in the chest at positive pressure is crushing the SVC or the IVC. Or another cause for pulseless electrical activity would be hypovolemic shock. Why I'm writing this information is mainly to sensitize you to the fact that for the right hand side, this would be called as non-shockable, because if somebody is having hypovolemic shock, then the treatment is not DC shock, then the treatment is put it a wide bore cannula, give IV fluids to the patient. If it is cardiac tamponade, you will be doing pericardiocentesis. If it is tension pneumothorax, you will put a wide bore needle in the fifth intercostal space, or maybe even in the second intercostal space, especially for pediatric cases. Or if it is asystole, you would be giving adrenaline to the patient. Whereas the left hand side is shockable rhythm, so you have to give CPR for 2 minutes and simultaneously obtain IV abscess. Now the computer will check if the rhythm is shockable or not. It will deliver the DC shock for the second time, and if in spite of giving DC shock for the second time, though you see this is the first shock that was given, this is the second shock that is given. I told you after first shock continue CPR, put a IV line. The sequence is to be remembered. After the first shock, give CPR to the patient for 2 minutes. One cycle of CPR is for 2 minutes, and get a IV access. Then deliver DC shock number 2. Continue the CPR once again. You can see CPR is being given after every DC shock because you want to continue. You don't want to interrupt the blood supply to the brain. Now through that IV access, you can give epinephrine. The query in the mind of a lot of people is that, sir, epinephrine is used in cardiac arrest when there is a flatline ECG to restart the heart. Why are you giving epinephrine in a ventricular tachycardia, ventricular fibrillation scenario? So the reason why we are giving it here is because epinephrine here would cause vasoconstriction, and this would increase the coronary flow, and because it will act on the coronary circulation also, it will cause constriction of the vasoconstriction of the coronary circulation, and it will also increase the coronary flow, and this would reduce the hypoxia in the heart. By reducing the hypoxia in the heart, we can achieve improvement in the perfusion, and therefore the cause for ventricular tachycardia, ventricular fibrillation, that is hypoxia, will relatively reduce. And in case you have delivered DC shock for the second time and still there is no improvement, you would give the third shock. Again, continue with the CPR and then use either amidron or lignocaine as the case may be, especially for ventricular tachycardia protocol. The message is that 3 DC shocks would be given with respect to the left hand side, and for each one of them this is to be followed by CPR. But the differences are, in the first box you secured IV access. In the second box, you use that IV access to give epinephrine to the patient, which will cause systemic vasoconstriction, and that will increase the coronary blood flow. And the third time, what you did was you used amidron in the patient. So this table steps is what I would like you to imprint in your brain and can be asked, because right hand side is straightforward. No, you have to give adrenaline in a flatline ECG, no big deal. But the left side is worth its weight. Now, if I come back to the slide of ventricular tachycardia, you will notice that all these broad QRS complexes were almost of equal size. So I will also prefix a word here. The word is monomorphic, because the amplitude of all these broad QRS complexes is equal. So we are going to call it a monomorphic ventricular tachycardia, and compare this with what is shown subsequently. You still can be seeing these broad QRS complexes, but each one of them are having a variable size. Because of the variation in the size of the broad QRS complex, we are going to call it a polymorphic ventricular tachycardia. This is well known by its Latin terminology. The Latin term that is used for this would be torsadis de pointis, and our examiners, they, because they love to use classical terms, so it's always a good idea to read about it. And they also ask you regarding the drug of choice for this condition. See, even if this particular person of polymorphic ventricular tachycardia is having an unrecordable BP, then I would be proceeding with DC shock in the patient. But if he just mentions the word drug of choice, then magnesium sulfate is good enough. Lots of time they may not ask you regarding the diagnosis of this patient, but they might say what is triggering it. So torsidis de pointes can be triggered by electrolyte imbalances. Yes, torsidis de pointes can be triggered by electrolyte imbalances, and one electrolyte imbalance that they would love to ask you here would be hypomagnesemia, magnesium deficiency. Another electrolyte imbalance that can contribute to this is hypokalemia. Very important points, guys. They ask you for all of the tachyarrhythmias, no, they ask you the treatment. But for polymorphic ventricular tachycardia, they can ask you regarding the causes here. And the causes could be like class 1A, class 1C, class 3 antiarrhythmics. When I write this, the query of most people is, sir, antiarrhythmics are supposed to cure a patient, and you are telling us that they are causing a arrhythmia. Then yes, guys, the point is a medicine could also be a toxin. If you give too much of something, it can cause a problem. So antiarrhythmic drugs can be a villain also, that they can trigger torsidis de pointes. So majority of questions that are asked on polymorphic ventricular tachycardia, I mean the traditional DOC part is understandable. I mean most people will get right. So the examiner might actually ask you about the causes which are present here. And one of the drugs that I can say was withdrawn from the market because it used to trigger polymorphic ventricular tachycardia was cisapride. Now we progress to the next ECG. And here what I want to draw to your attention is that the QRS complex of the patient, the amplitude is again variable. The QRS complex of the patient is sometimes small and sometimes bigger. And just a few minutes earlier also I was saying the same thing, na, that the QRS complex amplitude will be variable. But what is the difference between the two conditions is that this is a very fast tachyarrhythmia. I mean the RR interval of the patient would be hardly, less than one large square or almost reaching 1 large square. So the heart rate of the patient is very dramatically increased to 300 per minute. Look at the inferior ECG which is shown to you. You will notice that the RR interval of the patient would not be having that dramatic fast rate. In fact, if I just count the heart rate here, this would be approximately, and we can do it at least 2 times here. So this would be about a little more than 2, or I would say 2.5. So the heart rate in this patient is not dramatically increased. The formula here would be 300 divided by 2.5. So the heart rate will work out to something in the range of about 125 beats per minute, not reaching up to 300. I can also pick up a normal sinus rhythm because I'll use an alternative color. This is a P wave, and then I can also see a T wave, and I'll use same colors once again. The green is representation for the P, and then subsequently there's a T wave present. In fact, a finer pen should be used here, and you can see the T wave. There is a slight variation in the with respect to the amplitude that is coming up. Let's do this again with a different color actually, so that there is symmetry present. Okay, so once I zoom it in, you will see that the green is representing the P wave, then is the blue representing, I'm looking actually in the screen, so I'm just highlighting that green is representing the P, then is the QRS complex, then is the T. So there is a normal sinus rhythm in the patient. This normal sinus rhythm was not present superiorly. I mean, if you compare the two strips, there is no normal sinus rhythm superiorly present. It's only broad QRS complex tachycardia, whereas NSR is present. But still there is variation in the amplitude of the QRS complex. So this is NSR. There is a slight tachycardia. There is still variation in the QRS complex amplitude. But this is definitely not a polymorphic ventricular tachycardia. This would be called as electrical alternance. Where would you be getting electrical alternates? You would be getting it if there is fluid accumulation around the heart. That would be pericardial effusion. So in the pericardial sac, normally the amount of space in the pericardial sac would be hardly about The fluid would be 20 ml approximately for lubrication purposes. But here what is happening is that instead of 20 ml, it could be going up to 100, 200, 250, 300 ml. So because the amount of fluid is suddenly increasing, it could be pressing on the heart from outside. This condition that I'm showing before you at the moment would be called as pericardial effusion. I could have even written the word cardiac tamponade, but cardiac tamponade is where the fluid will accumulate very fast and will crush the heart. You see, let me say in tuberculosis, the fluid will take maybe months to develop. As a result of it, the pressure on the heart may be limited. Pericardial effusion and cardiac tamponade, the difference is that in cardiac tamponade, the fluid increases very fast and the amount will also be more. So whenever you read this term electrical alternance, you will have a tendency to think in terms of cardiac tamponade, because yes, cardiac tamponade will occur in this patient after maybe a limited time when the amount of fluid increases. But if you read the term electrical alternance, your first answer would be given as pericardial effusion, which is one step before cardiac tamponade develops in a patient. The highlight of electrical alternance will be that the amplitude of the R wave will not be the same. The amplitude will be lesser, but patient will be in normal sinus rhythm, whereas in the superior ECG, there was no normal sinus rhythm present in the patient, and there was a variation in the amplitude of the broad QRS complexes. So both the aspects have to be remembered. I'll repeat the facts once again. Point number one to be remembered is whenever you get a variation in the amplitude of the QRS complex, don't be in a rush to answer it as polymorphic ventricular tachycardia. Check whether P waves are present after PQRS, then T wave normal sinus rhythm should be demonstrated. If that is so, your answer would be given as electrical alternance. Now, pericardial effusion can deteriorate to contribute to cardiac tamponade, which will have an unrecordable BP. And tension pneumothorax also has unrecordable BP. So there was a question that said, how do you differentiate between cardiac tamponade and tension pneumothorax? Because when patient came in both the situations, like it could be a polytrauma case, guy driving a car without a seat belt on, right? Like that Australian cricketer, no? Right? Simmons, he was driving a car maybe without a seat belt. The car accident occurred. I mean, the exact cause was not determined. This is what I'm speculating. If he's driving a car fast, in Australia, roads and Australian cars, I mean, people tend to drive fast. If the seat belt is not in place and the guy ends up in an accident, there could be cardiac tamponade and tension pneumothorax both occurring. Or it could be like you have to differentiate whether it is cardiac tamponade, whether it is tension pneumothorax. It might be either of the two, and the person is having unrecordable BP. Then one of the important features that will differentiate between the two will be that breath sounds will be absent in tension pneumothorax because the lung is collapsed, but breath sounds will be always present when it is cardiac tamponade. In cardiac tamponade, you will have muffled heart sounds, but that muffled heart sound can be a variation, or I would say muffled heart sounds may not be picked up, or muffled heart sounds, one doctor might say, okay, heart sound looks normal, other might say it looks muffled. So there could be an inter-observer variation. But with breath sounds, when I say present versus absent, it will be relatively easier for anybody to pick up. So the main differentiating feature between cardiac tamponade and tension pneumothorax from an MCQ perspective should be remembered as absent breath sounds, and cardiac tamponade would develop in pericardial effusion once the fluid increases in amount and it crushes the heart from outside, and it would limit the filling of blood in the heart. The aspect of non-chokeable rhythm is what I've already explained to you. And now let's look at this particular ECG, where the first and the foremost thing is you would be calculating the heart rate of the patient. So I can calculate approximately 4 to 5 large squares. So the heart rate is on the lower side of normal. In fact, I'll just do that again to be on the safe side. So I'll just put first pointers for this is 4, and then I would say a little excess from 4 and going up to here. So approximately 5 or slightly less than 5. So I can say the heart rate of this patient is more than 60 beats per minute. It's not a proper bradycardia. It's about reaching up to 5. So I said more than 60. The next thing that I'm noticing in this ECG would be with respect to the axis. I've told you that every time you calculate the axis, look at lead 1. So the vector for lead 1, R minus S, is positive in this case because R is bigger than S. And if you look at lead number AVF in the patient, here lead number AVF, R minus S, if you look, it's almost of the equal size. So I can put it on the plus side here only because R is slightly, or I would say almost equal side as that of S So the vector will point on this particular quadrant, which is normal. So the axis of the patient is normal at the moment. But when I start looking at the precordial leads, that is especially V2, V3, V4, I am able to see that the height of the T waves is going more than 10 millimeter. The T wave height is going more than 10 millimeter, going up to 15 in this case. You see, if I count here, this is 1, this is 2, this is 3. So because the T wave of this patient is increasing, I decided to get electrolytes checked. And what I found was that the electrolytes of this patient was deranged. The electrolyte that I'm talking about at the moment, where you start getting, this is just initial starting of hyperkalemia. So you will start getting tall tentative waves. I mean, when you say tall tentative waves, it would be a height more than 10 millimeter in the chest leads of the patient. In the limb leads, it would be height more than 5 millimeter. Remember, T wave normally is gonna be less than 5 millimeter when it comes to the limb lead, that is lead 1 to 3, and for the chest lead it would be more than 10 millimeter. Please remember that ECG is not very sensitive. ECG is not very sensitive to the electrolytes as it is made out to be. We all are under impression that every time we are going to have a hyperkalemia, we might be having tall tentative waves. I did pick up one and I decided to get serum electrolytes done. You know, lots of times serum electrolyte report might be showing a value of 6.5, maybe going up to 7, but the ECG findings may not directly correlate. So ECG is not reliable. It is serum electrolytes that need to be focused on. I mean, the report will be giving you more accurate status than ECG. So ECG is just supportive evidence when it comes to electrolyte imbalance. And one of the highlights of the ECG findings of hyperkalemia would be development of tall tentative T waves, whereas in MI we discussed regarding hyperacute T waves. Now ST segment also tends to follow the T wave. So as the T wave will increase in height, subsequently in the same patient, once the values will, let me say, start going up to 7.5, what we will also notice is, this is P, this is QRS complex, the T is increasing. And now what's going to happen in this particular patient is, as the T is going up, another finding that would come up is because potassium tends to slow down the heart. Potassium tends to slow down the heart, so the RR interval of the patient will be increased, and that explains why the heart rate of this patient was going towards the lower side of normal. It was more than 4 large squares, as I said, 4.5, so it was around about approximately 60. This is the ST segment. ST always follows the T wave. Because ST follows the T wave, you would be having a ST elevation. We are gradually building up the causes for ST elevation. I taught you ST elevation in ST elevation MI, Prince metal angina, and now hyperkalemia will also be having ST elevation. So this is how the same person's ECG would look like. In this particular case, what I'm showing is ST elevation occurring and the T wave is increasing in height, and then subsequently the amplitude of the P wave, the first wave of the ECG is the P wave. The height of this will start becoming smaller to the level that the P wave might actually disappear. I taught you P wave disappearing in atrial fibrillation. This is the second time that I'm teaching you that P wave will disappear in the ECG. That is the case of hyperkalemia. So you just need to mentally visualize that P is becoming smaller and T is becoming taller. And because the heart will become slower, so PR interval in the patient will also tend to increase because the heart is slower. And because the heart is slower, therefore the QRS will also begin to become broader. So let's just summarize the findings till now, and you need to visualize like this. In hyperkalemia, the first wave of the ECG, the P wave is becoming smaller. The T wave amplitude is increasing. The QRS complex will become broader, and this broad QRS complex will merge with the T wave. The broad QRS will merge with the T wave, and we will be having a very peculiar pattern developing in this patient. This is how it will appear, and this pattern that I'm now showing before you is called as sine wave pattern. This more looks like a mathematical wave than a wave of ECG. So sine wave pattern would be just before diastolic arrest in these patients, because hyperkalemia can cause death of a patient. The logic is potassium slows the heart. Because potassium slows the heart, so diastolic arrest can occur and it can cause mortality. Usually once the values go beyond 8, They can obviously be 9, 10, 11, 12, but the point is the moment values go more than 8, the chances of person expiring will be substantially increased. The logic is repolarization waves will tend to increase because potassium is related to repolarization, and the depolarization vector becomes lesser. So the P wave amplitude reduces, the heart is slower. So I said the RS complex of this patient will become broader and will merge with the tall tended T wave, resulting in a sine wave pattern. And the opposite of this can be seen with respect to hypokalemia. Before we talk about treatment for hyperkalemia, which will be discussed even subsequently in the electrolyte section with the kidney, but the ECG findings are to be given importance in this case. In hypokalemia, opposite happens, that the T wave amplitude becomes lesser, lesser, lesser. Earlier, the T wave amplitude was increasing. This time, the T wave amplitude will become lesser and will become absent to the level that you might even be having a T wave inversion. Now, the last time I mentioned T wave inversion was for a case of MI. Then T wave inversion can be seen in unstable angina. This is the third time that I taught you T wave inversion. That would be MI, unstable angina, and hypokalemia. Now, because ST will always tend to follow the T wave, and because the T wave is becoming negative, so ST would go down. So this is how the ECG of the same patient would look like. This is P, this is QRS, and now showing a ST depression with a T wave inversion. Let me just exaggerate the ST depression component here. You can see at the moment I've incorporated the second ECG finding, that is ST depression and concomitant T wave inversion present in the patient. Earlier, when I was teaching you hyperkalemia, I was teaching you the fact that there would be a decrease in the height of the P wave. Here it will be ulta. There will be an increase in the height of the P wave. The P wave height will tend to increase. This increase in the height of the P wave is what is called as pseudo P pulmonale. This was a old All India PG NEET PG MCQ. I think it was 2019 when this was asked. Pseudo P pulmonale, that's a feature of hypokalemia, and meaning of the word pseudo P pulmonale is that the vertical height of the P wave, the vertical height of the P wave is more than 2.5 millimeter in absence of pulmonary artery hypertension. Meaning of the word P pulmonale is that P wave height is more than 2.5 in the presence of pulmonary artery hypertension. But I'm not teaching you pulmonary artery hypertension, I'm teaching you electrolyte imbalance. So if this electrolyte imbalance is causing this issue, we are going to call it a presence of a pseudo P pulmonale. Apart from this, another ECG finding that would be developing in these patients subsequently would be a prominent U wave. We do have U waves present in ECG of normal people also. We do have U waves present in ECG of normal patient also. And the reason for U waves in ECG of a normal person is a delayed repolarization of papillary muscles. That's physiology. U waves is a normal finding, but if you read the word prominent U waves, that would always be hypokalemia. So this comparison of the ECG findings of hyper and hypokalemia are to be remembered. And as far as the treatment part of hyper K is concerned, I mean, multiple strategies and multiple drugs are used, and I'll emphasize and talk about them even subsequently when I talk about the electrolytes aspect. Now we solve a question here that was asked in the exam. The question said patient on amphotericin B is having a potassium value of 2.3 millicoulombs, and what is the correction to be given to this patient over the next 24 hours? Well, first of all, I want to sensitize you to the fact that in any person, the objective is to reach a safe value at least 3 millicoulombs per liter. Yes, I finally want to upgrade to 3.5 millicoulombs, which is the lower limit of normal. Normal values are 3.5 to 5.5. But this upgrade from 3 to 3.5 can be done even by oral route. I mean, once the patient is in a position to take orally, that is at values of 3 or little more than that, then oral pot chlor can be given mixed with water, and along with this coconut juice can be allowed, banana can be allowed, so the potassium values will come back towards normal. But to reach up to this threshold, of 3 millicoulombs in the blood per se, the increment that I'm requiring is 0.7 millicoulomb. And the question was saying how much KCl will you be adding to the IV fluid? Then the rule to be followed is this mathematical rule, that is to raise potassium in the blood by, listen to the mathematics carefully, to raise the potassium in the blood by 1 millicoulomb, 200 millicoulombs of KCl needs to be added to IV fluid. Like suppose the value was 2. So from 2 to 3, I need to give 200 milliequivalents of KCl to be added to IV fluids. Here it is 2.3, so it's an increment of 0.7. So all you need to do is a bit of mathematics here. The increment required is not 1 milliequivalent, it is 0.7. I'll just multiply this by 200 and I would be getting 140 milliequivalents of KCl, which are to be added to the IV fluid. Obviously, potassium is never given directly. It is to be added to the bottle of IV fluid, and over 24 hours, and the patient will be relatively better. Amphotericin B is anyway, I mean, a nephrotoxic drug, and it's associated with hypokalemia. So most of the mathematical calculations that are given in the exam is a one-step calculation. If you are doing some hi-fi calculation in the exam, that means that your mathematical question will go wrong, and they again don't provide paper and pencil, so you have to do it mathematically. And the main carry home message is, every time there's a calculation based question, it will be one step calculation. If you're doing some rocket science kind of a question, I mean, if you are erroneously doing it like a rocket science of a type of a question, this would mean that the thought process of the doctor who's attempting that MCQ is wrong. So from the ECG perspective, I've also talked about electrolytes, that is hyper and hypokalemia, which is to be remembered.